Yes, sir, we can start now, sir.
Yeah, thank you, Chitrakala. Good afternoon, doctors. I am Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I kindly request all the participants to post their questions in the comment box, and at the end of the talk, we will have a short Q&A session with the expert comments. And I take this opportunity to welcome our today's dignitary doctors, our chief guest, Dr. Shraddha Jain, ma'am, and our guest of honor, Dr. Sanjeevani Khanna, and we have a special guest, Dr. Sushil Gupta. And for the topic one, we have a speaker, Dr. Pratima Mittal, and the chairpersons are Dr. Kishore Rajurkar and Dr. Anita Kaushik and Dr. Lieutenant Colonel Lena and Sridhar. And for the topic two, we have a speaker, Dr. Josna Suri, and the chairpersons are Dr. Punita Mahajan and Dr. Ekta Bajaj and Dr. Abbas Sood. And for the topic three, we have a speaker, Dr. Rekha Bharati, and the chairpersons are Dr. Alka Jain and Dr. Divya Singhai and Dr. Mrinalini Mani. And I also welcome our convener, Dr. Jyoti Malik and Dr. Neelam Gupta. And before proceeding, we have a webinar. To the webinar, we have a short AV on Shield Connect launch, which is a digital platform. I request Chitrakala to please play the AV on Digital Connect. Yeah, this is a Shield Connect, which is a digital platform for connecting doctors at a one place with all the scientific literature and webinars and blogs. Shield Connect strives to improve the state of the patient care, adapting to the modern practices, and transforming healthcare with science driven by innovation. I request all the delegates to please log into the Shield Connect and please do have a look in our webinars and blogs. Yeah, thank you for giving us the time. And with this, I welcome all the dignitaries and the participants. And I request Dr. Jyotika Malik to take over and go ahead with the webinar. Yeah, thank you,
Yeah,
ma'am.
thank you, Dr. Someshwar, Chitrakala, and Mr. Praveen and Shield for giving us this platform and this app. We'll definitely see how beneficial it would be for all of us. And without wasting much time, I think since you have already given us the overview, what we are going to discuss today is the critical care in obs and gynae, and we have a wonderful panel of a galaxy of people who are going to speak on it. with a lot of experience. So we should not be taking away their time. And at the outset, I would invite our president of DGF Outer Delhi, Dr. Kishore, who's the head of department, Sanjay Gandhi Hospital, to please introduce our chief guest, Dr. Sharda Jain ma'am, the pillar of strength for the DGF, the founder of this DGF, and because of this DGF, because of ma'am, that we are here together on this platform. Dr. Kishore, sir. Sir, please unmute yourself. Sir, unmute yourself. Kishore, sir, you have to unmute yourself. Yeah.
Sorry,
Yes.
sorry for that technical itch. I welcome all of you for this wonderful webinar, and it is a privilege for me to introduce Professor Sharda Jain, and she is the director of Life Care Center and also the Life Care IVF, and she is one of the great teachers, and also she's also has achieved lifetime awards from many societies like Foxy and IMA and LHMC and others. And she's the one under because of which we are all under we are having all these seminars and webinars, and under her leadership I think we are going to progress. And main thing about her is that she's most approachable, and she's very knowledgeable, and her all her words and wisdom, we are very lucky to have her in our forum. Thank you.
Doctor, thank you very much for kind words, Dr. Kishore. I really don't require introduction because my role is not much. The experts are all here. Through this particular forum, whosoever is listening I must congratulate each and every gynecologist of this particular country to bring down the maternal mortality rate tremendously. This is the whole 1 millennium goal which the country could achieve. And every year we find that there's a drop in maternal mortality rate to the tune of 5 to 6%. But whatever the deaths are today, 120 per lakh, whatever it is, if you want to bring it down, the critical care in obstetrics is very important. If you want to save any life, the people have to be trained. Many times, walking through the corridors, I've seen our colleague, men doctors tell gynecologists as dais, क्या लोग सब करते क्या यार? दाइयों का काम करते. And this is true. This is true. We know we can do hysterectomy, but we hand it over to our husbands, who's an orthopedic surgeon, to do it. It's our doing. We just stand by the side of sister and only do Dai's job. You have to learn critical care obstetrics. I've decided certificate course will be given to every gynecologist in city of Delhi. The Delhi gynecologists will top as far as the critical care is concerned. And today, we have with us Dr. Pratima Mittal, who leads the show. That's the only hospital in the country who's equipped with critical care beds in obstetrics. She has gone across the country to do workshop along with Dr. Jyotsna. And I'm sure she will see to it that our dream of Delhi Gynecologist Forum is realized. I'm giving a challenge to her. If she doesn't do it, I will do it. I again repeat, I've decided about it. It has to be 12 hours live training program and only observership. Safdarjung takes the responsibility to give the observership fine. Otherwise, there are many tertiary hospitals are ready to do this. But I will take. Dr. Pratima Mittal has been a very dear colleague of mine. I respect her a lot for two things: for adolescent health and for critical care. I'm sure she will not let me down with Dr. Jyotsna Malik to design a very course. So at least Delhi can say that their gynecologists are at the top in this particular course. And I think today's topics which Dr. Jyotsna and Dr. Pratima has selected, this is the need for everybody. Not only people who are obstetricians, it is need for other people also. Topics which she has chosen is absolutely, we need to salute her, because each and every fundamentals have to be known in a very simple words by the gynecologist. There is only one critical hour, and that is 1 hour. You work, you save, you don't save. I lost my mother when I was 6 years old in a medical college. 10 hours after admission, my mother was lost. I know what critical care means, what the diagnosis means. So with these words, I'm looking forward to 2021 with a lot of hopes that this particular course will definitely roll on. Thank you so much for this particular thing. Over to you, Dr. Malik.
Thank you so much, ma'am, for your, DGF, you have taken such important topics, colposcopy, ultrasound, and now this critical care, which is actually the need of the hour. We have to actually thank you for taking up these important topics, which make us different from a DAI, because that is what a delivery anybody can do, but to know all these issues and basics of obs and gynae, we each and every obstetrician and gynecologist should know. So thank you so much, the whole of team of right from Dr. Pratima Mittal ma'am, Dr. Jyotsna and Dr. Rekha for giving us at one call saying yes to our request. Thank you so very much. Thank you. Coming on next, I would now request Dr. Alka Jain, our senior vice president of DGF Outer Delhi, to please now introduce our guest of honor, Dr. Sanjeevani Khanna ma'am.
Good afternoon, everybody, and thank you, Dr. Jyoti. Dr. Sanjeevani Khanna is a very well-known person in our field of gynecologists. She is a very beautiful person from inside and outside. She is the head and director of Obs and Gynae Fortis Hospital, Shalimar Bagh, New Delhi, and has been an ex-professor in the Department of Lady Hardinge Medical College. Madam has many awards and literature things for her on her background, and I think it is a great honor for us to have her as a guest of honor. Thank you, ma'am.
Thank you, Dr. Alka. Thank you, Dr. Kishore Rajurkar and Dr. Jyoti Malik and Delhi Gynae Forum, Outer Delhi. I am really happy today to see Dr. Pratima Mittal, who is my batchmate and good friend. And good friends are those, even if you don't meet them, you don't have any interaction with them, they still remain deeply connected to you. And I'm really happy to see dedicated people like Dr. Jyotsna and Dr. Rekha Bharti. I haven't really thought of what I have to say because I think all of you are going to cover the subject. All I want to say is, and actually an essence of what Dr. Sharda Jain ma'am has said. And from Dr. Jain, we all know what should be done. But if there is a central figure who's inspiring and pushing people, then that figure is a mother figure for all of us. We do follow the advice, and she will think the best for us and for the whole community. We trust that. For a pregnant lady, the spectrum from her having a very smooth pregnancy to a smooth delivery, all going well, perfect. The car is going in third gear, fourth gear. We are able to handle. There are no bumps on the road. But we cannot say we are good drivers if we will not uh, see a speed breaker in advance and brake slowly, and if we will not be able to put the vehicle in fourth gear, fifth gear, and we don't know how to put it in any other mode that we may need to in a four-wheel drive. So a four-wheel drive is a situation which is uphill task for us, and if our vehicle should be equipped with a four-wheel drive as far as possible. So we know the happy spectrum, but if we are able to sense that there is a speed breaker, okay, we may have some trouble if we don't brake. We should sense. Similarly, analogy is that patient is maybe turning sick. Then we have a situation in which the patient is sick and we have a steep uphill drive. We should be prepared. Without that, we are not drivers, and we are not good drivers. Then we lean on somebody else. You can't get out and tell somebody else, now you drive, I don't know how to drive. So I'm glad that the initiative of teaching, spreading critical care, how much fluid to give, which fluid to give, hemorrhage, hypertensive conditions, septic conditions, the importance of taking all precautions is being taken up by very tall figures, Pratima, Jyotsna, Rekha, who are huge figures because of their own hard work and their achievements. And if they spread anything across the country, it will be taken seriously. It will be followed. People will know what should I give. Patient is having PPH. They don't know whether to give, what drugs to give, how much dosage, which IV fluid to start, and how to sense that patient has infection or she has developed sepsis. So all these clarity on all these things is extremely important. I thank you very much for giving me this high position in this very, very important and need of the hour webinar. Thank you, Dr. Jyoti.
Thank you so much, ma'am, for joining, because you are also one of those figures we youngsters look up to. And now I request Dr. Ekta Bajaj, the senior obstetrician gynecologist, head of department Ujala Cygnus Group of Hospitals, and treasurer DGF Outer Delhi, to please introduce our special guest, Dr. Sushila Gupta ji.
Good evening, everyone. Dr. Sushila Gupta, she is MBBS, DGO, FICOG, PG, DHCA, and MBA Healthcare. She is Director and Senior Consultant Obstetrician and Gynecologist, GNH Excel Medical Center, Shalimar Bagh, New Delhi, and she is Consultant at Fortis La Femme Hospital, Shalimar Bagh. And she is Advisor DGF North since 2018. And she is Chairperson Breast and Cancer Awareness Screening and Prevention Committee from 2018 till now. And she had been President Delhi Gynae Forum and Chairperson Reproductive Endocrinology Committee and Chairperson Adolescent Committee. And she has received many awards like DGF Award for Excellence in Gynecology 2014 and recipient of APJ Abdul Kalam Excellence Award 2016 and Women Achiever Award, the IMA DNS 2019. Welcome, ma'am. Ma'am, we are so eager to hear from you. Please speak a few words.
Thank you very much, Dr. Ekta, such an elaborate introduction. I will not waste much time. I will just speak 2 lines. It is actually really honored to be here in this August gathering and for discussing such a dedicated meeting on critical care. And I must say these small steps to teach everyone will help to save maternal lives and eventually bring down the maternal mortality rate below what we have aimed to target. And I must congratulate Dr. Jyoti Malik for taking such an initiative and discussing such a crucial topic and choosing such a wonderful speakers and faculty to discuss. And the first step towards the vision of Dr. Sharda Jain ma'am, what she has shown us to teach every gynecologist how to treat critical care and these crucial moments of woman's life. All these words, I just thank you again for Shield and Jyoti and Outer West Zone. And I welcome you all. Thank you very much for giving honor to me. Really, I thanks from my bottom of my heart.
Thank you so much, Dr. Sushila. So coming on to our academic part, since we are running quite late, I would just introduce my chairpersons for the session. Dr. Kishore sir, we have already introduced. Then we have Dr. Anita Kaushik, the treasurer of DGF Outer Delhi, and Colonel Leena Sridhar, Lieutenant Colonel Leena Sridhar from Manipal Hospitals, the head of department. So over to the chairpersons so that we can briefly introduce our first speaker and then get going. Thank you so much. Dr. Anita, please unmute yourself.
Okay, Dr. Pratima Mittal, I am giving the introduction of our speaker, Dr. Pratima Mittal. And Dr. Pratima Mittal ma'am doesn't need any introduction. Dr. Sharda Jain ma'am and Dr. Sanjeevni ma'am has already said so much about her. She is the professor and consultant, head of the department of Safdarjung Hospital and Vardhman Medical College.
Thank you, Anita. I think we can continue with the session.
Okay, ma'am. Okay. Thank you so much, ma'am. Thank you. We can continue the session. Okay, ma'am.
So, good evening, everybody. I would like to share the screen. Can you see my slides?
Yes, ma'am.
Is it in full mode? Do I make it full?
Full kar dijiye, full nahi hai. Now it is there.
Good afternoon, everybody. Good evening, everybody. First of all, I would like to thank Dr. Sharda Jain for inspiring me and, having so much faith in me. And I must tell you, madam, I will do my best and I will not let you down as far as your expectation is concerned. We will definitely try to do everything as you desire. And it is definitely in the interest of the country, in the interest of Delhi chapter. Thank you, madam. And then I would like to thank Jyoti and all the Sanjeevni, Jyoti and Kishore and everybody else who have talked so high of our team. I'm really, honored to be here. And the topic which I'm going to talk today is, I'm not going to talk anything new. Only thing is we are just recapitulating the things which we have learned earlier also. So coming to my talk, I will be talking on assessment of critically ill obstetric patients. We all have talked about maternal mortality, and initially, maternal mortality ratio has declined from 167 to 122 in 2015 and 17. But the WHO goal is the target is to reduce the global maternal mortality ratio to less than 70 between 2016 and 2030. And why basically there is increased maternal mortality in developing countries. Basically, it is the deficiencies in managing critically ill obstetric patients, which have been highlighted earlier also by Dr. Sharda Jain. But mainly these deficiencies are due to knowledge gap, which we will try to increase by these seminars, webinars, communication gap, poor resuscitation skills, and availability of facilities where these patients can be transported and managed effectively. So causes of maternal mortality, we all know mainly it is hemorrhage, eclampsia, sepsis, anemia, and other medical causes. And our assessment should mainly be focusing in all these important causes. Coming to the talk, overview of my talk, I will be talking who is a really critically ill obstetric patient, why pregnant woman is different, why pregnancy, what are the pregnancy related anatomically and physiological changes, because it is important to understand them to manage the cases and the diseases. type of obstetric patients requiring management, and assessment of critically ill patients, important lab parameter, and how do we recognize these critically ill patients early. That is the most important part of this talk, because early recognition will definitely prevent maternal mortality. Who is a critically ill obstetric patient? Any patient, any pregnant patient, post-abortal patient, postpartum patient who is at risk for potential life-threatening conditions which can lead to maternal mortality will be labeled as critically ill obstetric patient. Why are obstetrical patients different than the non-pregnant patients? Because there are different anatomical changes which make them more prone for morbidity, physiological changes which modify the presentation of the problem, normal physiological variables, and response to treatment. And there are two persons which are important. Both mother and fetus are affected by the pathology. And as important, most important is that these patients are very young patients. And so, I mean, it is losing one patient means the whole, you have the quality of the family has been lost, as Dr. Sharda Jain has herself, suffered. The quality of the family suffers for, I think, ages, for decades. So, but we have always to keep in mind that mother's welfare will always take precedence over the fetal concern. Fetal survival is usually dependent on the optimal maternal management. So what are the pregnancy-related anatomical and physiological changes? Most important changes because of the hormones, estrogen and progesterone. There is airway edema, friability, which makes the intubation and difficult because of the edema. The visualization of esophagus and larynx is difficult, and there may be trauma to the while intubation. Then most important is that there is elevated diaphragm, which leads to widening of the subcostal angles, widening of the AP angles, and transverse diameter of the chest, leading to barrel-shaped chest, which will lead to, basically hypoventilation, low functional residual capacity and hypoventilation, and it can lead to difficulty in respiration in the later phases of life. As far as the cardiovascular system is concerned, we all know that there is increased cardiac output, increase as high as 30 to 50%. There is decrease in the stroke volume and increase in the heart rate. There is decreased in the systemic and vascular, pulmonary vascular resistance, leading to pooling of the blood in the peripheries, decreased mean arterial pressure in first and second trimester, and of course, enlarging uterus may compress the aorta to produce increased afterload and compress the inferior vena cava to decrease the cardiac return, resulting in supine hypotension. So what is the impact of these changes on the pregnant mother? Supine hypotension syndrome, hypotension, sinus tachycardia, and tachypnea is more common in these cases due to compression of inferior vena cava. And that is why we advocate left lateral position or LUD. Shock may be missed till significant blood loss because there is already tachycardia. And if it is alarmingly raised, then only shock may be identified, shock may be missed. Otherwise, besides that, catacolumn surge with blood loss constricts the uterine blood vessels, which leads to a fetal morbidity. And IV access should always be above the diaphragm. Otherwise, venous return is decreased. So there will be not proper intervention even if you give fluids from IV access below the diaphragm. As far as the respiratory system is concerned, I have already talked about functional residual capacity is decreased by 20% in pregnancy as the uterus enlarges and elevates the diaphragm. There is increased consumption by the fetus, and there is reduced functional residual capacity reserves, which will, there is increase in the tidal and minute volume, but no change in the respiratory rate. And what all does it lead to? It leads to decreased tolerance for hypoxia and apnea because of low functional residual capacity and increased demand. Respiratory alkalosis is more common because of the decreased PaCO2 and increased PaO2. We have already discussed, more prone to injury because tongue mucosa all are edematous. Difficult mask ventilation, again because of the increased intra-abdominal pressure and elevated diaphragm. Difficult airway and increased risk of aspiration because gastric emptying time is decreased and lower esophageal sphincter tone is also decreased. As far as so in normal pregnancy, in the late stages, there will be rapid shallow breathing, which will lead to make her more prone for respiratory alkalosis. Hematological changes, increased plasma volume. We have already talked about hemodilution and anemia, because hemoglobin is in second trimester generally comes down, hypercoagulable state, and fall in platelet count. These are the physiological changes which will lead to physiological anemia and lower platelet count in normal pregnancy and increased chances of thromboembolism. Renal changes, we have, we all know that there is hydronephrosis due to pressure of the gravid uterus. There is increased in the renal plasma flow, GFR is increased, creatinine clearance is lowered, low proteinuria is there, and there can be reduced excretion of sodium and water, and that can lead to reduced excretion of sodium water load can lead to resultant peripheral edema. Creatinine clearance, it is increased in pregnancy, and serum creatinine levels will load. So if it is serum creatinine levels are more than 1 milligram, then we should become alert. And altered renal tubular functions will be there, which will lead to increased risk of pulmonary edema because of the fluid retention. As far as the GI system is concerned and the liver is concerned, we have already talked that there is a reduced gastrointestinal motility and increased risk of aspiration and increased liver metabolism. And these changes will lead to prolonged intestinal transit times, and which will alter the drug metabolism. So we have to see the drugs doses have to be very, very careful regarding those things. And gastric emptying time is prolonged. So we have to see that these drugs are given and patients does not vomit, and the mechanism at the time taken, it should be taken into consideration. Otherwise, toxicity may be there. So this is all these physiological changes make a change in the parameters which we observed on the blood gas analysis. That is, the normal values are changed. In that, like in non-pregnant patients, the pH is about 7.35, but in pregnant patients, we take 7.40 as the cutoff for the pH values. And PCO2, PO2, bicarbonate, and SpO2, all these values are, little on the lower side in the pregnant patients. If you see, the PCO2 is 27 to 34 millimeter of mercury as compared to 35 millimeter in non-pregnant. The bicarbonate levels are 18 to 21 as compared to 22 to 26, and SpO2 is high. It has to be maintained at 95 to 100% because the fetus is there and the peripheral tissues should all be getting a proper oxygenation. So what are the type of patients, who require critical care? Either they're having conditions which are specific to pregnancy, like preeclampsia, AFL, acute fatty liver, obstetric hemorrhage, amniotic fluid embolism, etc. Or they are increased susceptibility in pregnancy, as we have talked about, just venous thromboembolism or aspiration syndrome, and underlying medical condition that is exacerbated, like congenital heart disease. And there are conditions which are unrelated to pregnancy and coincidentally developed during pregnancy, like diabetic ketoacidosis, pneumonia, COVID in pregnancy nowadays, and asthma, etc. So how do we identify? So main aim is to identify the etiology. Main pathologies are important, as we have discussed earlier: hemorrhage, hypertensive disorder, sepsis, thromboembolism, and medical disorder, associated medical disorders. So how do we assess any critically ill obstetric patient? First of all, our initial management should be to resuscitate the patient. The resuscitation of the patient is must in the cases in which we observe that the respiratory rate is less than 5 or more than 35, pulse rate is less than 40, more than 140, or there is a sudden decrease in the level of consciousness. So initial resuscitation is very, very important. Then second important thing is to relieve the aortic cable compression from pregnant uterus by LUD, left uterine displacement. Third is you should take a quick history, identify the pathology by the history and systemic examination. Systemic examination should be individually organ-based approach. And then you should also consider the age of the gestational age of the fetus whenever you are managing such cases. So these are the important issues whenever we are doing a assessment and initial management of the critically ill obstetric patient should be done first. The vital signs which you have to assess are, as we have been doing years altogether, assess the respiratory rate, oxygen, pulse, systolic blood pressure, her level of consciousness, temperature, and urine output. Coming to each one separately, I will be talking in short. Heart rate should be taken manually for 1 minute, noting the rate, volume, and regularity. Normal rate, we all know. Abnormal findings need investigations, and consider ECG monitoring or the vital monitors if you have got, then they should give you a better picture. Respiratory rate, relevant in a number of compensatory mechanisms within the body, it should be between 12 to 20. The most important is you have to see that whether there is a indicator of potential deterioration. Rising rate is often an early sign, but rate is not only important, it is also important to see that is there a use of accessory muscles, is there increased work of breathing, the patient is able to speak or not, is there a patient looks exhausted, what is the color of the patient, what is the position of the patient, is she sitting and talking, or is she dyspnea, she is dyspneic. All these things have to be assessed. Blood pressure is a very late sign. You should not, we should not keep on waiting till the blood pressure falls. Before that, respiratory rate, pulse rate, they are more important. Be aware what is normal for the patient, and it has to be seen that manual blood pressure recording may be appropriate. Or if you are using other apparatus, then it should be calibrated apparatus which should be used. And fall of systolic blood pressure for more than 30 millimeter should be considered as shock. Oxygen saturation, we all know that if oxygen delivery to the body falls below what is demanded, the tissue extracts more oxygen from the hemoglobin and the saturation will fall. So blood saturation of the oxygen is also important to be measured for assessment of the patient. All the cells are dependent on adequate supply. And if it is, clinician should be aware, we should be aware that the target saturation, which is more than 95% in pregnant patients, should be maintained. And if it is less than that, then the patient needs oxygen supplementation, and ABG may be required for more in-depth assessment. Urine output is a very sensitive indicator of hydration status. Dr. Jyotsna, when she's talking of fluid therapy, she will be talking about how to give fluid, and that urine output will tell us whether the fluid response is good or not. Generally, it is a poorly recorded observation, and it should be appropriate depending on the condition of the patient. In acute kidney injury, which is very, early signs of hypotension, that is the worst thing. Acute kidney injury can occur in a pregnant patient if the patient has got a lot of volume depletion, which will lead to decreased urine output. Level of consciousness, we all have to assess in every patient, if whether the patient is, alert, or whether she's responsive to only voice, or whether she's responsive only to painful stimuli, or she's unresponsive, and that should be recorded. And if it is patient is unconscious, then in those cases we have to take care of her respiration, because in those cases she will be the more chances of aspiration. So those cases should be given respiratory support. This is another Glasgow Coma score which anesthetists usually use. We are generally using the AVPU scale, which we have talked about the level of consciousness. In this Glasgow Coma scale is also easy to understand. It is only, you have to see eye opening, you have to see verbal response, and you have to see motor response. And accordingly, you will decide the patient is in very severe morbid condition, or it is a mild condition which can be managed. So if the score is less, up to 3 to 8, then patient needs an urgent intervention. Temperature, we all have seen that high and low both can indicate sepsis. So if the patient is having low temperature also, then one must think that the higher centers are not responding to the stimuli, so the infectious stimuli. So that is why her temperature is low. So that's a sign of severe sign of severe sepsis. So again, Dr. Rekha will be talking about sepsis, and she will be talking about this. So what are the important laboratory parameters? Most important is arterial blood gases. The picture which I have shown you earlier, we have to understand that pH less than 7.35, base deficit more than 6, -6, and bicarbonate less than 18, one should be very, very alert. And PaO2 less than 80, one should be very alert. Lactate is a very good indicator of telling the mortality, prognosis for these patients. So lactate more than 4 is very, very poor prognosticator. Less than 2.5, as I've said, is 5% mortality. Only, and more than 4 is 75% mortality. So one should be, really counsel the patient. If the lactate patient has been referred to and lactate is more than 4, then one should be really alert. Factors which affect lactate levels are also tourniquet for more than 2 minutes. So it is important to identify how the blood sample was taken. Besides that, urine PCR ratio is more important. Nowadays, 24-hour proteinuria is generally not required. It is the single urine protein creatinine ratio. If it is more than 0.3, one should think of renal involvement and renal dysfunction. One should check the coagulation system, platelet, blood, BTCT generally do not give very good information. PT and INR as well as APTT will all tell you about the DIC and such patients. So one should order for platelets, prothrombin time, APTT, fibrinogen and fibrinogen degradation products. After doing all the history examination, and one have to identify the etiology, which can be either hemorrhage, or it can be most commonly hemorrhage, hypertensive disorders, or sepsis. And in those cases, the treatment has to be done according to the etiology itself. Additional elements in relation to the patient care here will be the consent, the privacy and dignity of the patient, documentation, infection control, and communication. I think we as a gynecologist, we do not give importance to these, important at times, we do not give importance to these parameters like, privacy and dignity, communication, especially in the public hospitals. And we have to teach all our, postgraduates and everybody that one has to maintain privacy and dignity. One has to maintain, good relation with the patient and the attendant. And most important is documentation, because nothing can save you, just documentation. So for medico-legal purpose, documentation is the only thing which can help you, fight these cases. So we have to maintain a chain of safety, measure observations and document, recognize deterioration as a gynecologist, as a clinician, communicate appropriately, respond effectively, and reassess. And before that, before I go to the, conclusion, I would like to say that in many cases, it has been seen that the early warning signs of the impending maternal collapse are unrecognized. And because they say that it is, rarely I have such an event in my hospital. Generally, we are dealing with a healthy population. So what should be done? We have to identify these early warning signs. And this can be done, this should be done even at the early, first stage, when the patient is even in the primary health center or in a nursing home where your patient has started deteriorating. So we have to identify early warning signs so that if any abnormal vital sign parameters are there, the patient can be shifted to a facility where she will get an appropriate care. And the facility should be such that appropriate person and appropriate care, if given, which can be able to prevent the major morbidity and critical illness. Sorry. So what are the clinical markers? So this is a very, very important thing, for all the gynecologists. and even the paramedical workers, they should identify this shock index. Even in our casualty now in gynae receiving room, all the senior residents have to write the shock index if the patient is coming to them in a critical condition. This is a very simple tool to calculate heart rate divided by systolic blood pressure. In the normal shock index range is 0.5 to 0.7, and it is a potential predictor because most common causes of maternal morbidity and mortality is hemorrhage. So it is a potential predictor of hypovolemia. And if it is a shock index is more than 0.9, it is abnormal in obstetric patient, and one should become very alert and send the patient to an appropriate facility. Modified shock index, again, it is here the systolic blood pressure was incorporated in shock index, and in this we have incorporated MAP, that is mean arterial pressure. This is calculated by diastolic blood pressure plus systolic blood pressure minus diastolic blood pressure divided by 3. And if it is more than 1.3, it is significant. It is a stronger predictor of emergency patient mortality because as compared to the shock index, heart rate divided by blood pressure are known, because it does not have the significant correlation with emergency patient mortality rate, the shock index. But at the moment, I think even if we include shock index, it's good enough. You will be able to identify the patient who are at risk of having severe morbidity. The other important thing is, especially in the hypovolemic patient, especially in the hemorrhagic patient having postpartum hemorrhage, is the rule of 30. 30% loss in blood volume, moderate shock. Systolic BP fall by 30 millimeter, get alert. Heart rate rise by 30 beats, be alert. Respiratory rate rise by 30 beats, be alert. Urine output less than 30 ml per hour, be alert. Hemoglobin drop by 30%, be alert. So this, I think everybody should have, these things to be put up in their labor rooms or anywhere, so that if nurses or even junior doctors report to you immediately, and the patients who are deteriorating are picked up early. Then coming to the SOFA score, which is now we are requiring only clinical data for assessment and can be performed quickly. That is the systolic blood pressure less than 90 millimeter, and respiratory rate more than 25, and altered mentation, that will be given, all are given score one each. And if the score is more than 2, then in those cases patient is at risk of having high chances of severe maternal morbidity. Another model which is very useful for the pre-eclampsia cases, which we predict the model, the maternal mortality in these cases, is the Pierce model, and this takes into account parity, gestational age, headache, chest pain, vaginal bleeding, and systolic blood pressure, etc. The full Pierce models requires laboratory testing also, but otherwise the clinical Pierce models is used for assessing the patient's condition. Besides that, there is an early warning system, which is a use of set of predetermined calling criteria, which is based on periodic charting of the vital signs as indicator that allow early recognition of patients, so that they can be aggressively managed and transferred to a higher level of care. So what is this modified early obstetric warning system? This should be there, followed at all peripheral health centers, all the labor rooms, and whenever you feel, and even midwives, nurses, they can be taught to mark these system, modified early obstetric warning system can be taught to learn about the marking of this system, in which you have to measure temperature, respiratory rate, blood pressure, pulse, and oxygen and urine output, etc. And in this system, you will put the normal values. If they are coming into the white there, then you should be just okay, it's okay. If they are coming in the yellow, then 2 yellows are making the patient very, moderately sick, and they should be referred to a higher center. And if it is 1 red alert, then one should send the patient immediately to a higher center, or one should call the shift the patient to ICU settings. So this chart should be there. This chart should be there in all the labor rooms, and all your nurses, all your doctors should be monitoring the patient using these charts. And in this chart, this modified early system, the limitation of modified early system is only that it was developed on the basis of inputs from highly informed experts without formal prediction models. So Carle et al. Produced another system in which they came with a statistically designed and clinically modifiable early morning score, which is Carle modified score. And this is what we follow in our hospital. In this, you give values like -1, 2, -2, -3, or normal and +1, 2, 3. And accordingly, systolic blood pressure, diastolic blood pressure, respiratory rate, heart rate, oxygen saturation, temperature, and conscious levels are entered. And if the values are 1 to 3 in aggressive aggregate score, then the patient needs low grade response. 4 to 5 in the aggregate score, or 3 in one abnormal vital sign, then medium response. But if it is more than 6, then the patient needs a high response. And we have done at Safdarjung, we have done a study with the Carle Muse at the Safdarjung Hospital, and it has shown very, very clearly 1,000 patients have been assessed, and the sensitivity of the score in predicting ICU and HDU admission has been found to be very significant. And so I would just like to say that critical illness in pregnancy is a challenge in both diagnosis as well as in management. One must understand physiological changes associated with pregnancy, and at the same time must recognize the signs suggestive of deterioration, maternal condition, and at the earliest, and refer or manage the patient accordingly. Thank you very much. These are the references which I have been referring to in the slides as 1, 2, 3, 4. And this is our ICU where we are managing such cases. Due to COVID now we have, and social distancing. So we have reduced the number of beds. We have made 2 zones, orange zones and the green zones. And at least instead of 10 patients now, we are, reduced the number. So we are facing the problem of ICU facilities not available at times. But probably with COVID, we will be able to go on. I think COVID coming down, we will be able to do better. Thank you.
Excellent presentation by Dr. Pratibha. I would just like to make a few comments. I think we all know that, and why this critical care is important. It is important because the pregnancy is a physiological phenomenon. And if something happens to a person who is having a normal thing, then this cannot be taken as a normal thing. And we know that any nation's growth or whether assessment of the medical health is through the maternal mortality. And the most, we are having a seminar or webinar on a critical care. The most important thing in critical care is the prevention. That the person should not reach at this level that she requires this critical care. Why I am saying this, that the maternal mortality ratio of India is around 122 or so. But if you see the maternal mortality ratio of other countries which are in Asia, let us see, if you see the Saudi Arabia, the MMR is 15, which is equal to USA. The MMR of Iran is 25. The MMR of Iraq is 50. The MMR of Sri Lanka is 50. Why we cannot achieve it? If these countries, maybe that it is they are smaller countries, but still I think there is a scope. And the most important thing there is that 99% patients get the antenatal care. Here there is some problem here, and if you have that care, our critical care patients also will be less. Second thing which I want to say is that it is the recognition that this patient is sick that is missing. So many times we see कि सारे कर रहे हैं, ब्लड लगा रहे हैं, सब कुछ हो रहा है, but it is too late. because the resident is not able to know that whether she's actually sick or not. वो तो बात कर रही है जी, वो तो उसका तो BP ठीक है जी. So this is the thing. I think all the teachers and all of us should teach them that first you must recognize that something is wrong, and then only then I think. Otherwise, we'll not be able to bring the mortality as early as possible. After that, because Dr. Pratima and Sabdan had wonderful HD unit, I visited that place, and I set up an HD unit in Sanjay Gandhi Hospital. So it is not that easy, because in a government hospital it is not that easy to set up. But I think all the hospitals, because any patient can become sick, and you cannot refer any patient suddenly to a bigger hospital. So you have to have something there. So I think all the hospitals should have at least 1 or 2 beds. At least there should be an HDU level, and it is not impossible. It is possible to get it done. And we have purchased a small iStat also, that a machine in which in few drops you can get all the important reports, and you don't have to send all the reports to the lab and then wait for the reports. So because of this COVID, and हमारे को ना वो teaching of the actual teaching is becoming more difficult. हम webinars तो हम कर लेते हैं, they all know theoretical they know everything, they will know, but when it comes to the patient वो थोड़ा सा problem होता है. I think you mentioned about the Glasgow scale, that is more for a trauma thing, but other scales are very, very important, I think. And another thing, many of the patients are septic patients, septicemia. So there is a difference if the patient is having septicemia and if the patient is having septic shock. There's a lot of difference in mortality. If it is 20%, it becomes 60, 70% there. Therefore, I think you have to act fast and do it. But overall, it was a wonderful talk, and I think we should have a big clock in the labor room and allow bajna vichi alarm. 5 minutes ho gaye, 10 minutes ho gaye, 15 minutes ho gaye. So that particularly in PPH cases, I think it will be very good. Thank you very much, Dr. Pratima, for that excellent talk.
Thank you. Thank you.
Dr. Pratima?
No, ma'am.
Thank you. I think most important is the prevention, which I have talked about. That is which I have said, the MEOS. I think everybody should be following that MEOS. That is just a simple, and shock index, just simple shock index.
Excellent. Bilkul.
Especially, if I may add, Dr. Pratima, it was just wonderful hearing your talk. And I think this Carl's MEOS is one index which I think we all can right away start implementing in our hospitals. And I have in fact noted it down so that I can pursue this part in my hospital. One thing which I think Dr. Kishore has also mentioned very correctly is recognizing the early signs. What is really happening is, you never know which patient is going to deteriorate. And what is so important is to recognize, and most of the time it is much too late. In fact, I've had to intervene in a case where a person was operating, and it was the anesthetist who called me. Could you just go and help out? Because she was, she had delivered twins, and there was PPH, and she was carrying on managing the PPH, and it was just going on. It was the anesthetist who actually alerted that, this 2 liters of blood loss has already happened, and we've got to make a decision quickly. But she was trying all conservative methods and not really realizing how much of blood loss had happened. And that typically happens when you are operating and, there's no one to alert you. In fact, I intervened and told her we've got to go in for a hysterectomy, and we did that pretty fast, and that's how the life was saved. So that's one of those things, which tells you that things are going wrong, and we have to know. Identifying the etiopathology, I think that was one very important fact which I'd like to also highlight. Initial management that you mentioned, I think that's really nice, and we must put up these charts right away, like resuscitation, taking a quick history, doing a left lateral, putting the patient in left lateral to remove the itocaval compression, quick evaluating the gestational age of the fetus, and doing a systemic assessment, all of which should happen simultaneously. Having said that, most of us don't have the privilege of sending the patient to a higher center. We've got to do what we have to do there itself, even in the tertiary care private hospitals. Training and more training. In fact, we've got to have a monthly drills on how we are going to what are we going to do when our patient crashes. And this, we have seen it, many a time, that when the patient crashes, we find there's a new lot of nurses who have come there, who are little, hesitant to do the drill. And so we got to do it every month, so that we keep repeating all the steps, and therefore everybody gets used to handling these patients. What is important is those early warning signs. I think those are the ones which we will have to stress upon, so that we pick it up and strike early and strike hard. That should be the message that we try out of this. Anyway, wonderful presentation. I've really enjoyed and kept glued to hearing every word of what you said. Thank you so much.
Thank you so much, our chairpersons, Dr. Kishore, Dr. Leena, Dr. Anita. And we have to keep on glued together another 1 hour more, because the next ones coming are still more important. And whatever Dr. Pratima has told is each word actually one should remember. So coming
Dr. Jyoti, I just have to make one point, rather ask Dr. Pratima that in ICU, we have the closed model and the open model and the hybrid or the in-between model. So in your ICU, since you've been a sort of pioneer in this effort, so do you practice a closed model, open model, or a hybrid or transitional model of care? I mean, what's the role of intensivists in your ICU?
See, I don't know, we closed model or open model, but it is mainly the HDU. What we say is HDU or ICU. And
Yes.
there's a mixture, like government is also proposing a mixed model, that is a hybrid model, in which few beds are for HDU and few beds are for ICU, which have got a facility for intubation and invasive ventilation. So that is what we are following in our hospital. In my department, we have got 10 beds which have got ventilators, and there's 6 beds which have got only, no ventilators, but they have got all monitors and everything. So 16 beds are there, and out of those 6 beds, they are mainly for monitoring. Basically, if you see, every patient does not need ventilation. It is mainly importance of monitoring. It is monitoring, which is most important. And before, as Dr. Leena also said, we are conducting training every month. Every month, my residents who are going to the labor room, who are going to the emergencies, who are GRR, that is the receiving room, or who are going to the HDU, they are given a class. Every month, we have got a 2 to 3 hours class, in which Jyotsna talks about shock management, management of collapsed patient, and labor room management. So this class is regularly, because you have to, every time you have to push into them that this is the right way. That is how we could introduce shock index. We could introduce this scoring, MEOS. Leena, I would like to say that MEOS is much easier, because you have got, you can download it from the net, and there's got a color coding. So color coding is very important as far as the, nurses.
It's almost, ma'am, it's almost just like a partogram, actually.
I think I just wish to tell you that, the very basics have to be there. We must know, unless we at PGI, we were taught rule of 100. If the pulse goes above 100, if the BP comes in less than 100, and if the urinary output is less than 30, alert. So what I feel is, at these small things, if every resident and every nurse is alert, then we don't require that kind of things with that. There's small things need to be alerted, and that's what is required.
I think we can discuss later, because we have 2 talks. I'm sure I would like to discuss with Dr. Pratima about the open and the closed systems of ICU and the hybrid. It is related to under whom the patient is actually. Closed is under intensivist, open is under the gynecologist, and hybrid is when both. So it's a question of who will give orders for the patient.
Okay.
What IV fluid?
Just in one line, I will say that obstetric HDU has to be under obstetrician. Has to be under obstetrician. We have to take help of an anesthetist. Our anesthetist come every day in the morning, but basically they see only the ventilated patients. You know, patient on invasive ventilation are being seen by them. Otherwise, rest of the things, I think everything is managed by my, you know, critical care in charge, Dr. Jyotsna Suri. She is managing every day the person who goes from duty, off duty, gives it over to Jyotsna. She personally takes care of each and every patient. So that is the most important thing. So
yeah, that's very practical.
Yes, and
yeah, that's
because anesthetists don't understand everything.
Yes.
Thank you, Pratima.
Thank you so much, ma'am. Now it is time to listen to Dr. Jyotsna now. I would welcome my new set of chairpersons for this talk, Dr. Punita Mahajan, our Senior Vice President, DGF Outer Delhi, and Head of Department, Ambedkar Hospital. Welcome, ma'am. Then we have Dr. Ekta Bajaj, our Treasurer, and I've already introduced Dr. Ekta here. And then we have none but a very, very dear and senior friend though, Dr. Abha Sood, who is the unit head of Jaipur Golden Hospital and President DGF Northwest. So over to the chairpersons and to introduce our very, very important next topic and the speaker there. Over to you, ma'ams.
So it's always a pleasure to interact with Team Safdarjung because I have some relation with Safdarjung when I worked there for 2 years with Dr. Pratima, and they have gone a long way, and I'm really, really honored and impressed. So now we have the expert in critical care, Dr. Jyotsna Suri, who is an authority on critical care obstetrics. At present, she is Professor, Department of OB-GYN at Safdarjung and Vardhman Medical College, New Delhi, and in charge of the critical care obstetrics. She has a long list of honors to her credit, but we'll go straight away in tasting the pudding as the saying goes. So welcome, Dr. Jyotsna Suri.
Yes, thank you very much. Thank you, ma'am. Can you see the screen?
Yes, yes.
Okay, so I'll make it full screen. Is it visible? Yes. Okay, so very good evening to everybody and to all the respected seniors, chairpersons. I'm really honored to be here and thank you, Dr. Jyoti, for organizing this. Thank you, Dr. Sharda Jain, ma'am, for all the encouraging, words and for being such an inspiration. And I'm sure, as Mittal ma'am just said, Dr. Mittal said that we would definitely try to live up to your expectation. Under Dr. Mittal's leadership, I'm sure we will be able to achieve all the goals. And I start now with the talk, which is, fluids and blood products in obstetric shock. And this is, I think, one of the pillars of critical care management is the fluids. So I am not going to be talking about fluid management in a stable patient today because we are talking about shock per se. When we do the courses for our, delegates who want to learn more, have more insight about fluid, we would talk more in detail in all the situations. So today I will only be restricting to the shock, and I'll start with this case study, which is a very, very representative case, which all of us, at least in the tertiary care hospitals, we have seen such cases every day. They come to us and they represent, the neglect of, the lack of knowledge about, how to do the proper volume resuscitation at the right time, and then the repercussions of such cases. So Mrs. X came to the emergency with history of home delivery 3 hours ago, followed by retained placenta and massive bleeding per vaginum. On examination, her pulse rate was 140, BP was 80 systolic, skin was cold and clammy, and she was very pale. Her respiration was fast, and her SpO2 was 86%. And only few drops of urine were draining from the catheter. A 20 gauge IV cannula was secured and normal saline was started at the rate of 40 drops per minute with 20 units of oxytocin. So 2 units blood were arranged and the placenta was removed. Carboprost was given and the bleeding was controlled and patient was shifted to the ward. And 2 units of blood were further transfused in the next 12 hours. So far, so good. Patient improved. And later on, what happened that she started having oliguria, which further worsened into a full-blown acute renal failure or acute kidney injury, as it is called nowadays. And then patient had to be referred to higher center for hemodialysis. So what went wrong? So this is the representative case or the base on which I start my talk. And the objectives of this session are how to identify a patient in shock and determine if she requires fluid resuscitation, types of IV fluids and which fluid is used when, how to determine that the fluid resuscitation is adequate, what is massive blood transfusion, what are the components and the risks. So first of all, identification, Dr. Pratima has already given a beautiful talk about how to identify, a critical patient, but for the shock, I've already highlighted, the important things. So the hypotension is the most important and a mean arterial pressure of less than 60 millimeter of mercury. So that is something which we all should, immediately spot, because many patients may have a BP which may be 90 by 60 or which may be 88 by 60 or 88 by 58. In pregnancy, we know that the BP does fall. But if we calculate the mean arterial pressure and we see, so we know exactly that what we are dealing with. And the first, identification of early shock is the narrowing of the pulse pressure. So once especially in the hypovolemic shock, when the patient bleeds, the sympathetic action, starts taking place, the vasoconstriction takes place and the narrowing of pulse pressure. So the diastolic blood pressure will rather increase. And when it is less than 25 millimeter, it is again a warning sign. And shock index already has been told that more than 0.9 is a very, very crucial finding, which we can actually identify shock. Then altered mentation and oliguria. So altered mentation, we always tell our juniors that if somebody is very irritable, they are talking irrelevant, don't straight away rush for a psychiatric call. Please see that what is the reason, and it may be most of the times that we are missing that she's in hypoxic condition, she's in a state of shock, which we are, missing out, and rather we are calling the psychiatrist to give her some medication. So all these are very important when we identify for early identification of shock. Now, quickly, the types of shock, there can be the hypovolemic shock, cardiogenic, distributive, and obstructive. So hypovolemic and distributive are the most important 2 types of shock which we people see very often. The hypovolemic shock is due to the low preload because of reduced intravascular volume, which happens in any condition of hemorrhage, diarrhea, vomiting, etc. And distributive shock is the one in which actually there is the volume is normal, but then there is a vasodilation with cooling of the blood in the lower extremities. And this leads to basically the low blood pressure and a state of shock. And this is typically seen in the septic shock, neurogenic shock, and in the anaphylaxis. So the others are the cardiogenic and the obstructive shock. Cardiogenic also, we people as a referral center, very often we see cardiogenic shock. Here the most important are the cardiomyopathies and the heart failures. Here there is actually the pump failure. So basically, the obstructive shock is one in which there is a low preload because of the obstruction of venous return to the heart due to the pneumothorax or the pulmonary embolism. So talking of what is fluid resuscitation and in whom do we give? So fluid resuscitation is the administration of fluids rapid and in bolus to patients with acutely impaired hemodynamic status. These 2 are the most important keywords. It should be given very rapidly and in boluses. And we'll, I think as we go ahead, you'll all understand why these 2 words are highlighted. Who needs fluid resuscitation? all the patients in hypovolemic shock and septic shock. So basically, the hypovolemic shock and the distributive shock patients are the ones who require fluid resuscitation. And how do we know that a patient needs fluid resuscitation? Conventionally, it is used. Conventionally, we all know, we have all grown up with the, the teachings that a central venous pressure should be established. And if it is less than 8 millimeter of mercury, the patient is in shock and she needs fluids. And of course, the mean arterial pressure, as I said, is low. But now the teaching is that CVP is a static measure and is not a very, very sensitive indicator about fluid responsiveness. Rather, there are the dynamic, measurements which guide us to know that who is fluid responsive. So there is a clinical, very, very, very simple test. We don't need to put in a CVP line. We don't need anesthetists at that point of time. When you see a patient in shock and you think that, should I give her fluid or not, and there are many such situations that the patient has come, her urine output is low. You don't know whether she is already gone into renal failure. Should I give a fluid challenge or not? So this test is very simple. It can be done by all of us. You just have to take the blood pressure first at the baseline when her head is raised at 45 degree, then make the patient, raise her legs for about 3 minutes. And in both the situations, we take the pulse pressure. So if the pulse pressure in the first position and second position increases by 9%, then we know that this patient is fluid responsive. So what it does, that there is a rush of blood from the lower extremities into the circulation, into the heart. And this blood is around 300 cc rush of blood is there. And if the BP increases, that is the pulse pressure increases, we know that this patient will do well with fluids and she needs fluids. So this is a very simple test. Another test which we can all do is simple, is ultrasound actually with the echo probe. And you have to just see the inferior vena cava. One can easily learn this, to see whether there is the collapsibility during inspiration. More than 50% collapsibility means that the patient is fluid responsive and she can be given more fluid. So these simple tests can help us to know that which patient needs the fluid. Now the question is, which fluid is to be given? So whether it is the crystalloid or the colloid. So we all know again that crystalloids have a low tendency to stay intravascular because of the small molecules, and they exert a low oncotic pressure. And within 30 minutes, they equilibrate between the interstitial space and the intravascular space in a ratio of 1:3. So if we give too much of these fluids, we can end up with the pulmonary or the cerebral edema. But still, they are the fluid of choice in the immediate resuscitation of the lost volume. Whereas the colloids, they have a high tendency to stay intravascular more than 24 hours. They can stay intravascular. Larger molecules are there. They exert a more significant oncotic pressure, and volume expansion is also better. But then why we are not, you see this simple diagram that if you are giving NaCl or you are giving 5% albumin. So NaCl is a crystalloid, 5% albumin is a colloid. So after half an hour, you see how much of this fluid is within the intravascular space and how much is in the interstitial space. And you see the first situation, that is the D5W. So D5W, we see that hardly it is inside the intravascular space. 0.9%, that is the sodium chloride, that is still there. 1/3 of it is still inside, 2/3 has come out. And 5%, you see that more than 3/4 is inside. So it is, the question for all of you that if it remains inside the vessel, why we don't do primary resuscitation with the colloids. Now, the answer will just come after this slide. First, I want to show all of you the crystalloids which are given for fluid resuscitation. The 0.9 or the isotonic saline, it is called lactated ringer. And these two, fluids, you just compare with the, I've already, put the plasma characteristics, the pH, sodium, etc. So if we see this, the lactated ringer is the most physiological fluid for fluid resuscitation. It is closest to the plasma. And also it has the added advantage that it has got lactate of 28 milliequivalent per liter, which actually gets converted to bicarbonate in the liver. And we know that in the case of shock, there is a metabolic acidosis and the bicarbonates are low. So overall, it is a win-win situation with ringer lactate. Sodium chloride is also a very good fluid, but it is got some problems, which I'll just tell. Basically, the problem with the sodium chloride is that it is, too much of it, more than 3 liter, can cause metabolic acidosis. That is the non-anion gap, normal anion gap metabolic acidosis, because of the high chloride content. And also very high amounts of transfusion with this can lead to renal dysfunction. So these are the two things we have to worry about. But ringer lactate, what are the flip sides of that? Because everything has got something, flip side. There is potassium in it. So if there is a case of renal failure with hyperkalemia, we have to be very cautious.
Index to be put up in the labor room.
Pardon? Hello? Yeah. And another thing is that we should be cautious when we are giving it in the same line as the blood transfusion, because the calcium is there in this. Again, ringer lactate has calcium, which can bind with the citrate in the blood. So these two things we have to remember when we are giving large volumes of ringer lactate for fluid resuscitation. Now, as I said, that colloids are not the choice for resuscitation. And the reason being that they can lead to severe coagulation abnormalities. Multiple studies have shown that they can lead to coagulation abnormalities, and there is a higher risk of mortality in women or any shock patient who has been primarily resuscitated with colloids rather than crystalloid. Anaphylaxis can be there, and acute kidney injury, especially with hydroxyethyl starch solutions. And even though it remains within the intravascular space for a long time, but eventually there may be, after 24 hours or after 2 to 3 days, these solutes, they remodel and they go into the interstitium. And also in septic shock and other condition, there is endothelial injury. So they will leak into the interstitium. And then because they are bigger solute, they draw a lot of water, and they can lead to very severe pulmonary edema, which can be very, very, long standing and can lead to rapid deterioration of the patient. So these are the problem with the colloids. 5% dextrose should never be given as a resuscitative fluid. I already showed very little volume is left inside. It is basically a hypotonic solution. It is a D5W. It is a water. So if we give large volumes of 5D to a patient for resuscitation in shock, all that water will go into the cells and it will lead to cellular edema. So 5DW should never be given for resuscitation. The fluid for resuscitation are normal saline and the ringer lactate. And for only D5W we give during hypoglycemic spells for to the patient. And the 3% saline or the hypertonic saline is given only in hyponatremia. So how do we administer IV fluids and how much is to be given? This is the grading of blood loss. So as per the, because when we are actually monitoring blood loss, as already mentioned that by Dr. Leena, that we are sometimes, we are not able to pick up the exact amount of blood loss. So, we do lose so much of blood is lost in hidden loss, and we don't know. And all these pictorial methods are there which can guide us. But in spite of that, hemodynamic stability of the patient is the most important. And this, I think, if we can put up in our labor rooms or in our emergencies, this table or this chart, it can guide us that, what class of blood loss the patient belongs to, because class 1 and class 2 do well with crystalloids, whereas class 3 and class 4 need to be given blood. And pregnant women, because of the hypervolemia of pregnancy, they have got, by nature, they have got the, they are protected. So they can lose much larger amount of blood to the tune of up to 2000 liter, 2000 ml, 2 liter, and still they may be relatively asymptomatic. But then when they crash, they will, suddenly deteriorate. And it is very important that we pick them up, in the class 1 and class 2 stages with all the signs which we have already discussed. So how much of blood has to be, how much of fluid has to be given depends upon how much is the estimated blood loss. And if we are estimating 1 liter, as we discussed crystalloid, we have to give 3 times. So we will give 3 times, that is 3 liter. But having said that, if the estimated blood loss is say 2 liter or 3 liter, we cannot give 6 liters of crystalloid to a patient, because that can lead to pulmonary edema and cerebral edema. So the limit of fluids is something like 2.5 to maximum 3 liter. Beyond that, we cannot give fluids to the patient for resuscitation. So fluid should be given in boluses. So how much to administer? It is 3 times whatever is the estimated loss in pph, and it should be always given in boluses if we want to increase the cardiac output, because if you give it slowly, it will again, as I told you, redistribute between the interstitium and the intravascular space, and you will not get that, increase in the cardiac output. So give it in boluses. In the first 15 minutes, give at least 1 liter of fluid, rush it. And in the second, half an hour, give the second liter. So 2 liter, if we give over 1 hour, we are going to achieve some, degree of increase in cardiac output. And for the sepsis patient, if the patient is in septic shock, it has to be 30 ml per kg body weight. Has to be given in the initial 3 hours of recognition of septic shock, which Dr. Rekha will be talking about. Even if the patient is in mild, congestive cardiac failure or in the renal failure, a patient who comes in shock always needs the fluid. But in these patients, high-risk patients, we will give smaller boluses. We will not give 1 liter at a time. Rather, we'll give 500 ml or even 250 ml, and then keep reassessing for signs of pulmonary edema. So it is not that we will not give them, because they do need fluid if they come in a state of shock. And how to administer it? It has to be either through the central venous line or through peripheral line. With the peripheral line, it has to be always a green or a gray cannula. Green is the 18 gauge, because with this you can give 100 to 120 ml per minute, and that means that you can deliver 500 ml within 5 minutes. If you give it slower with a pink or blue cannula, you will not achieve what we really want to do when the patient comes in shock. There is, in the periphery, the intraosseous axis is now, WHO is talking a lot about it, especially for in the periphery where, central venous axis cannot be, and even patient is coming with collapsed veins. So it is very simple. We people don't use it because we have the services of our anesthesia colleagues who will immediately come and put the central venous line. But in the periphery, intraosseous access is a very good method for initial fluid resuscitation of a patient. Other supportive care in shock: keep the patient warm. Fluids should be run when we give massive fluids, 1 to 3 liters, fast fluid. We have to give it through a fluid warmer. Hypothermia can actually lead to worsening of the patient. If we are giving in this cold weather, we run the fluid. It can lead to sympathetic stimulation, myocardial ischemia, those shivering of the patient, it will lead to myocardial ischemia and worsen our patient, and it can also lead to coagulopathy, even sepsis. So always give it through fluid warmer. And correct the metabolic acidosis with bicarbonate if the pH is less than 7.15, because sometimes if the pH is very low and you are doing everything, your patient will continue to bleed and the BP will not come up because she is in acidosis. So all the things have to be dealt with together. And how do we assess? You have to keep seeing her vital signs, that she is coming up or not. What is her mean arterial pressure? What is the urine output? And is the lactate improving? Is her mental status improving? So if all these things are occurring, we know that she is responding and she is improving and we are going in the right direction. And at the same time, keep seeing the basal crepitations, keep auscultating. Those are the early signs of pulmonary edema. And if we are getting, basal fine crepitation, we know that enough of fluid has been given. Now coming to quickly about the blood. So if there is a massive loss of blood, fluid will not be just able to restore the oxygen carrying capacity of the blood, and we need to give the blood and component therapy. So fluid is only till the time we are able to arrange. This is about hypovolemic shock when the blood has been lost. In the septic shock, it is only the fluid which needs to be given. But this particular thing I am talking when there is a PPH or an APH and we have lost a massive amount of blood, we have to give blood and component therapy. If they are in the class 3 or the class 4, as I showed in the table, they have lost more than 2000 cc, we have to give the blood. So blood has to be given. If there is a loss of more than 1500 to 2000 cc, even if there is a loss less than 1500 cc with ongoing bleeding, we have to give blood. And if our patient already was pre-existingly having a low hemoglobin, she cannot tolerate maybe even 1 liter blood loss, and we have to give. So what is the hemoglobin baseline? That is also very important. And massive blood transfusion, what is it? There are historical definitions. Olden days, it used to be, say, replacement of 10 units of red cell in 24 hours in response to massive and uncontrolled hemorrhage. But now, because things are very quick, we do not wait for full 24 hours to say that. So now it is 3 units of red cell over 1 hour, or any 4 blood components in 30 minutes. We say that it is a massive blood transfusion, or more than 50% of blood volume in 4 hours. So once we have, to whom we have to give massive blood transfusion, those who are acutely bleeding and who are acutely, hemodynamically unstable. Those are the patients in whom we have to give. And the most, common condition these days to whom we give massive blood transfusion is the placenta accreta spectrum disorders, which, I think is the most common indication of massive blood transfusion these days. Here we give transfusion of products by the rule of 4. This is, the 4 units of Paxil, 4 units of FFP to prevent dilutional coagulopathy, and 4 units of platelet. And if the patient is still bleeding, we may need to give the cryoprecipitate. So when we give massive blood transfusion, we should be aware 2 IV lines should be there. First line, we only give the blood products, and the second line, you give the cryoprecipitate, platelets, and the FFP. Whole blood transfusion is a big no-no these days. We all know it. There is no justification to give, except in centers where they are not able to do the component separation, and only there where the non-availability, it is the only condition in which it is justified. Packed red cell are the choice component of choice in any patient who is bleeding. So it is not that all patients need massive blood transfusion. Any patient who has lost 1500 cc blood, and you see that she's, you are doing all the measures to stop, you can initially just order 2 PRBC. We don't need to then do the massive blood protocol of 4:4:4. We just give 2 PRBC, improve her oxygen carrying capacity. And if the bleeding is curtailed, we don't need more. The target hemoglobin to be achieved is about 7 gram%. Once we achieve, we do not need to give more. And important thing is that we should complete the transfusion within 4 hours. So not that we just keep on lingering with it. The more hours you take to give the blood, you are going to create more problem. The transfusion reactions are much more commoner if we give it very slowly after 4 hours. So it is, said that if your transfusion is not completed by 4 hours, you discard that unit. And it must be used within 30 minutes of removal from the refrigerator. The PRP, again, we have got either the PRP or the apheretic plasma, the apheretic platelet. That is the single donor platelet, which improves the platelet count by 40 to 50,000, whereas the PRP only increases it by 5 to 8,000. So it should be again transfused immediately and completed within 30 minutes. And important here is that ABO and RH compatibility for platelets is required. So if you are having O negative, like these days we are having problem with the blood, negative blood, lot of problem we are not getting. And if the patient is needing platelet, it becomes a nightmare. So in such patients, you have to, if you give positive blood, you have to then give the anti-D to these patients. FFP, again, to prevent dilutional coagulopathy, we in the massive blood protocol, we give it, or else if the patient is in DIC, or she is having abruptio, or you have already seen that the INR is high, you have to give FFP. So target INR, make it less than 1.5, dose is 12 to 15 ml per kg body weight. Here, ABO the compatibility is needed. However, the RH compatibility is not required, and we can give FFP of a positive patient also to a negative patient. Cryoprecipitate only in cases where there is massive hypofibrinogenemia, or when the patient we need to give, in renal failure, especially if your patient has gone and you have to fluid restrict, then we prefer to give cryoprecipitate rather than the FFP, because FFP has got much more volume. So the important aspects for blood transfusion, no evidence of benefit of warming blood when it is slow. But when we give fast at the rate of 50 ml per kg per hour, we need to warm it through the fluid warmer. Routine use of pre-medication is not recommended. Use separate lines, I've already said. And if the patient needs more than 3 to 4 units of blood within 24 hours, calcium must be administered. So I just want to stress here that hypocalcemia is very common if because of the unmetabolized citrate, if you give massive blood transfusion. And it is seen that low calcium is a very high cause of mortality in the patients who receive massive blood transfusion. It is much more predictive than even the fibrinogen levels or the degree of metabolic acidosis. So it is said that one must monitor calcium every 15 to 30 minutes while the massive blood protocol is activated. And it is very simple. We all know how to give calcium gluconate. We give it in our magnesium toxicity cases, 10%, 10 ml, give it over 3 to 5 minutes. And, it is, or even calcium chloride we can give. So we should be very, very cautious about this. And the other problem with the massive blood transfusion is the hyperkalemia. So keep monitoring the electrolytes, because these two are the conditions which can lead to sudden cardiac arrest. So if our patient is bleeding, you are doing everything, and then suddenly she has cardiac arrest, it may simply be because her calcium went too low, or she went into hyperkalemia. So these things are very important when we are managing such cases. So I think the case study, we all know what went wrong and what we should have done by now. After listening to this presentation, I hope everybody is able to take home these important messages, that IV fluid should be administered in discrete boluses through wide bore short cannula. Initial fluid replacement should be with isotonic crystalloid solution. Ringer lactate and normal saline are fluids of choice for resuscitation in shock. And D5W should never be used as a resuscitative fluid. Large volume resuscitation using isotonic saline may be associated with hyperchloremic metabolic acidosis. And lactated ringer should not be infused in the same line as blood. Replace 1 liter in first 15 minutes and second liter over 45 minutes in hemorrhagic shock, pending the availability of blood. And for patients with severe hemorrhagic hypovolemia, RBC transfusion is the appropriate initial choice for volume resuscitation. For septic shock, infuse minimum of 30 ml per kg body weight of crystalloids in discrete boluses and start vasopressors in the first hour itself. And monitor very carefully the signs of adequate fluid resuscitation as well as fluid overload. So that is all for this talk today. Thank you very much for giving this opportunity and for the patient hearing.
Yeah, thank you, Dr. Jyotsna, for beautifully highlighting the need and how to go about giving fluids and blood products. I think as an obstetrician, we have been always depending upon the anesthetist colleagues to manage the fluid, but I think we've learned today that it's not difficult. With little expertise and knowledge and training, this fluid management can be definitely done by the obstetrician, and it's better to do it ourselves because we will otherwise lose, that one golden hour. So you have really beautifully highlighted. Thank you very much. And the carry home messages were very clear that we have to first identify the shock, and identification is very important. If we miss the opportunity of identifying the shock, we will be losing the battle. And then we have to, of course, define the type of shock it is, because the management will vary according to the type of the shock. And then you have beautifully highlighted how much fluid to give, crystalloid and colloid, when to give. And I think the messages were very clear. Thank you once again. I just wanted to talk to you about a replacement of calcium. Calcium gluconate replacement should ideally be given only in massive transfusions, I think, and not otherwise, because earlier we were giving regularly, but now we don't require it unless patient is having a massive transfusion.
Yes, if minimum 4 pack cells have been given, then we should actually monitor. If it is less than 1.17 millimole per liter, then definitely we should give the replacement. But if we don't have facilities for monitoring the ionized calcium, normally they say if you have given 4 pack cells over 24 hours, then you should give the calcium replacement.
Yeah, that's what I just wanted to say, because sometimes we cannot monitor calcium and potassium regularly. So we should follow the dictum that in case we are giving massive transfusion of more than 4 PRPs, then we give calcium. And a rule of 4, which you said very rightly, we should follow that. And it is not just the replacement of blood. And I think there's no rule of whole blood. You have already said that. And we have to follow this rule of 4, follow it by giving PCVs and then FFP and platelets in the ratio of 4. I just wanted to ask you to clarify that when we are giving pack cells, we give 4 units of pack cells followed by 4 units of FFP and followed by 4 units of platelets, or do you want to divide between 2:2, then give 2 PR FFP and 2 platelets? What is the dictum you follow in your center?
Yeah, so as such, there is no hard and fast rule that we have to, we can give it side by side also, because we need it, we have to give it through separate lines. So normally in the massive blood loss, when it is taking place in the operation theater or in the labor room, we can actually give it side by side. So there is no such thing. And if it is, that her oxygen carrying capacity is the most important at that time, then we can give the pack cell first. And if she is oozing from everywhere and we are suspecting she has gone into a DIC, then we may give the FFP and the platelet more rapidly. But ideally, we should be giving it together from 2 separate lines.
Right, very rightly said. So if it is the blood loss, then we give pack cells first. And if we feel that the patient is going into DIC, then probably very rightly said, we should give FFP and platelets simultaneously through a separate line and rapidly. Thank you, Dr. Jyotsna, for beautifully highlighting. And I think this kind of training, as has already been expressed by my other colleagues, is very essential, that we should undergo these kind of training with our residents monthly, or initially in the beginning even more frequently. Thank you, Dr. Jyotsna.
Thank you, ma'am. Thank you so much.
Dr. Jyotsna, can I put up one word?
Yes, sir. Sure.
I think take home messages में ना, I think जो भी हाई रिस्क पेशेंट हैं उनके लिए 2 कैनुला लगने ही चाहिए, चाहे कुछ भी हो जाए. I mean, once they are there in the labor room, whether you start the fluid or not, it is not important, but the cannula मतलब अंदर होना चाहिए. अच्छा, number two, I just wanted to know that because many of our patients are severe preeclampsias, many of them, and when they go into PPH, then the fluid management becomes the most difficult thing, because intravascular contraction hai, if you give fluid, they will go into the pulmonary edema. I have seen a lot of patients, I mean, we have lost also some patients. So can you just put a word regarding these patients?
इनसे कल पक्का लेंगे.
Sir. So if we have estimated the amount of fluid loss, the blood loss, that is very, very important. If we can give it, how much they have lost, you can give that safely. But having said that, it is not always easy. They may have lost it somewhere outside and come, especially those abruptio. Lina, I think you have to mute yourself. Lina,
somebody is talking, please.
Lina, I think.
Okay.
Lina, please mute yourself. Yeah. So, sir, this is what is a big challenge. So herein comes the role of our passive leg raising test, and the role of doing the ultrasound and the inferior vena cava collapsibility, and also if we are trained to see the lung, if there are B lines, once they appear, that there is already fluid overload. So if we have got the point of care ultrasound, we can very easily manage these without putting in a CVP. Otherwise, you need to put CVP and then give the fluid. But definitely, if you have assessed how much is lost, we can give that safely. There is no risk at all in that,
So very rightly said, it is the assessment of fluid loss that's very important. And this simple test like passive leg raising test, I think we should all practice that. And of course, as Dr. Kishore said, it's definitely a challenge to manage the fluid balance in the pre-eclamptic patients. But if we follow the simple principles of assessing the fluid loss, doing this test timely, this challenge, of course, and with the expertise and training which we are getting from you people and the various other programs, we will overcome this challenge, definitely. Thank you, Dr. Jyotsna, once again.
Can I have clear my one doubt? I'm Dr. Abha Sood. In cases of massive transfusion where you are anticipating RBCs and FFP to be given, so what is the role of giving whole blood in such patients?
Ma'am, as I already mentioned, the role of whole blood now is in modern obstetrics and in modern medicine. The role of whole blood is now practically not there. We are not giving whole blood to any patient nowadays, except in cases where we are not having the facility to have component therapy. If the blood bank is not equipped, in those cases only the whole blood is given. And then also because within 24 hours, the platelets are, they do not remain, viable in the temperatures which are required for storage of blood. So the platelets will, the activity finishes within 24 hours. So if at all you have to give whole blood, you have to give it within the first 24 hours of collection. If the screening has been done and all the HIV and the blood bank officer is satisfied that there is no infection in the blood and they are this thing. So within the first 24 hours, sometimes, if you give, then you may have some benefit. Otherwise, we don't really prefer whole blood at all nowadays.
So I understand it's mainly the coagulation factors which will be lost.
They are lost. They are lost. Yes, ma'am.
Like in obstetric practice, Safdarjung has such huge number of deliveries. So do you still cross-match the blood, or you find only the availability of blood? In the private sector, this is an issue. What do you suggest for us?
Yes, ma'am. I think that's a very important question. We do cross-match in all cases. We prefer to give cross-match, but that said, it takes 40 minutes for cross-matching. So in a case where unexpectedly you have faced a PPH and the patient has gone into shock, where we expect blood loss, like our placenta accreta spectrum, we have a scheduled patient for laparotomy. Here we already have our cross-match blood, but In an unexpected situation where we do not have the blood cross match, we ask the blood bank officer to give us group specific uncross matched blood, because we cannot wait for 40 minutes. So here there is a small risk of reaction, but then to see the risk benefit ratio of the patient's life is at stake, and every minute counts. So here we have, at some occasions, we have used non-cross-matched blood also in dire emergency situations.
Thank you. That's a good insight. Thank you very much.
And Dr. Abha, also that, the whole blood, the chances of fluid overload will be more with whole blood, whereas the benefit we are getting by giving a single donor, like, the increase in the platelets would be much more.
Yes.
And of course, as already highlighted, the coagulation factors will all be lost. So the risk of, running, and the blood which is available usually is more than 24 hours old, the whole blood. So we don't get any additional advantage at all.
I get your point. Thank you.
Thank you so much, Dr. Punita ma'am, Dr. Abha ma'am, and Dr.
Yes, blood bank do not provide whole blood. They just provide component. Most of the blood banks do not provide whole blood these days. I don't know. Any hospitals or any private blood bank, they are not giving whole blood. They are just giving blood component. Whenever we require only blood, then they are giving pack cell only.
Yes. Now the old blood is of no value.
Whole blood is not giving. Any blood bank is not giving whole blood these days.
Yeah, it's not available.
They are giving pack cell only if you are asking for the blood, and if you are giving more infusion, like more than 4 or more than 2, then definitely other component are also required.
Yes.
Yeah. Thank you so much. Thank you, Dr. Jyotsna, for clearing, for the crystal clear deliberation that you've made, and cleared all the doubts, so many that we all had. Maybe we can carry on with the discussion at the end, because we still have a very important, very important talk by Dr. Rekha here. So for that, I would invite my next chairpersons, Dr. Alka, the Vice President of DGF Outer Delhi and Senior Consultant, Sehgal Neo Hospital, Dr. Divya Singhal, the Vice President, DGF North, and Dr. Mrinalini, the President of DGF Southwest and Ambedkar Hospital, the Head of Department, Ambedkar Hospital. So over to Chairperson.
Guru Gobind Singh Hospital. Guru Gobind Singh Hospital.
Pardon? Guru
Gobind Singh Hospital.
Sorry.
Not Ambedkar.
Okay. Actually,
Punita is in.
Yeah. Sorry, very sorry. So coming over to you, Dr. Mrinalini, and because we have the third very important part still left, and we are overrunning.
Yeah. So I welcome Dr. Rekha Bharti, and she's also a very important part and managing the critical care unit in Safdarjung Hospital. And without wasting further time, I would like to invite her to give us very valuable inputs regarding her expertise and her management, and then we can share the discussion in the end. Welcome, Dr. Rekha.
Thank you, Dr. Mrinalini. I am sharing my screen, and I would also like to thank the DGF Outer Delhi for giving me this opportunity to present this very important talk. Yeah. Is my screen visible?
Yes, ma'am.
Yeah. So I'm going to talk about the golden first hour in the management of septic shock. So first of all, just a small thing about introduction of the sepsis. We all know that the definition of sepsis has changed in 2016. Previously, we used to have multiple terminologies like sepsis, severe sepsis, and septic shock, and there was a lot of overlapping in these terminology. But now the definitions have been simplified. So we just have sepsis and septic shock. So when we say sepsis, it is basically a life-threatening condition where there is organ dysfunction, which is because of the dysregulated host response. And this dysregulated host response is caused by infection. So, if we just see the definition of sepsis, it is the organ dysfunction definition is very clear. For this, we have SOFA score. Though it is an extensive score, but still you can have these tables available with you and you can define organ dysfunction. If there is increase of 2 or more points on the SOFA score, we say there is organ dysfunction. But infection, is the definition of infection is a gray area. So like previously also we were discussing, the main problem comes with the residents or the treating doctor is not able to identify the situation. So this is very much true in some kind of infections, because there are no guidelines to identify the presence of infection. It is only on the basis of clinical suspicion and with the supporting data from your radiological findings and your microbiological findings, which are available later on, and the response to therapy that that patient has infection. Now, septic shock is when the patient has sepsis and despite of adequate fluid resuscitation, patient requires vasopressors to maintain a mean arterial pressure of more than or equal to 65 millimeter of mercury. And also when the lactates are more than 2 millimoles per liter. So now why it is important is because as soon as the patient shifts from sepsis to septic shock, the mortality increases from 10 to 40%. So it is very important to identify this condition. This is SOFA score. We all can make out it is very extensive and you need certain investigations to score a patient according to this scoring system. So we have a quick SOFA score also available. This is actually nothing, but you just see the vitals of the patient and you see the mentation of the patient, respiratory rate and the systolic BP. And every parameter is given a score of 1. If the score is more than or equal to 2, it is associated with poor outcome. So basically, generally, we provide this to do this kind of scoring in our emergency or in the ward. And we know that these patients, they need a higher level of care. So sepsis in obstetrics is important because we know it is associated with 15 to 20% of maternal mortality. And one very important thing is that a patient with sepsis can rapidly progress to septic shock. This may happen within 24 hours. And in few kind of infections like group A streptococcus infection, it can be within 2 hours, the patient from sepsis goes into septic shock. So now the new surviving sepsis guidelines, which came available in 2018. So what is the basic difference between the previous 2016 and 18 guidelines is that previously we used to have 3 hours and 6 hour bundles. So now this 3 hour and 6 hour bundle is combined into a 1 hour bundle. And what is actually, it means that the resuscitation and management of the patient should begin immediately because the time is very crucial in sepsis. So what does this 1 hour bundle mean? So this is basically that clinicians, they begin the treatment immediately, and especially in the patients who are in shock, rather than waiting for extending resuscitation over 3 to 6 hours. So more than 1 hour, it is, beginning the resuscitation, but your resuscitation may continue after 1 hour also. It is not that it is going to be complete within 1 hour, but we have certain parameters which need to be started within 1 hour of presentation of the patient. So why this first hour is golden hour in sepsis is because sepsis is a medical emergency. Nowadays it is graded like polytrauma, acute MI and stroke. As we say that in these conditions, we have to begin our management as soon as patient comes to us. So similarly, it is with the sepsis also. So this, the component, 1 hour component, which is there, it is that there are 5 parameters to it. So 5 points which are important. First is the lactate should be measured, and you have to remeasure lactate if your initial lactate levels are more than 2 millimoles per liter. Second thing is that you have to obtain blood culture before administration of antibiotics. I'll be coming to each point in detail later on. Third is that you administer broad spectrum antibiotics and begin rapid fluid administration. This has already been covered by Dr. Jyotsna, the importance of it in septic shock. So 30 ml per kg of crystalloid solution is what we aim at, and especially patients who are hypotensive and where lactate levels are more than or equal to 4 millimoles per liter. And the fifth very important point is that you have to start vasopressors early. Previously it used to be said that you give fluid resuscitation, and if the patient is not maintaining mean arterial pressure of more than 65 millimeter of mercury, you start vasopressors. But with this 1 hour bundle, it is that even when your fluid resuscitation is going on and patient's BP is not picking up, you have to give vasopressor, because we have to realize that this kind of shock is redistributive shock. So there is no fluid loss as such, But actually, because of the decrease in the venous tone, the capacity of the vascular system has increased. So that is why vasopressors are very important in this kind of shock. Now this 1 hour starts from time 0 or the time of presentation. So next thing is, what do we mean by time 0, from where the 1 hour starts? So time 0 is defined as the time of triaging in the emergency. Like patient has come to you and you are seeing the patient for the first time and you suspect that patient is in septic shock and you start the management. Second thing is, you may be having patient might be referred from some other center and you may have the charts of the patient or the progress report of the patient available. So you can count the time from that period when the patient went into hypotension or developed sepsis. So the first thing which is there in the 1 hour bundle is the measurement of serum lactate. Now this is although a weak recommendation with a low quality of evidence. Why? Because lactate actually is not a direct measure of tissue perfusion. What it tells us is that there is tissue hypoxia, but this can be used as a surrogate of tissue hypoperfusion. And we know now from the RCTs, we know that there is significant reduction in the mortality if we do the resuscitation guided by the serum lactate level. So this is considered now a very important parameter in the resuscitation of the patient in septic shock. So if the patient's lactates are more than 2 millimole per liter, then you have to remeasure within 2 to 4 hours. So what it is going to tell us is whether the perfusion of the tissues has improved with your resuscitation or not. Now, the second point of the 1 hour bundle is that you obtain blood cultures prior to antibiotics. Now, why it is important is that we know that within minutes of giving antibiotics, the cultures can be sterile. So there is no point in collecting the culture after you have given the antibiotics. So to optimize the identification of pathogens and improve the outcome, culture must be obtained before giving antibiotics. So appropriate blood cultures include at least 2 sets. One is the aerobic and one is non-anaerobic cultures which are obtained. And in addition to blood culture, culture should also be obtained from the urine. And if there is any focus of infection, like in our obstetric patient, we collect the high vaginal swabs. And then also, if you have any wound, episiotomy wound or the laparotomy wound or cesarean wound, which is infected, so cultures should be collected from that site also. Now, the administration of the appropriate, this is very important. You know, you may be are there at a situation where you do not have the facility to collect the culture at some hour of the day. So it is not that we are going to delay the antibiotic therapy if we cannot collect the blood culture. So this is very important that the antibiotic therapy should not be delayed if you are not able to collect the cultures. It is important, but should not be delayed. Then the third recommendation is that you administer broad spectrum antibiotics. So this also has to be started within 1 hour of the presentation. So the goal is to achieve higher drug concentration, which are sufficiently effective to exert the maximum killing at the site of infection. So see, it is very important in septic shock because many a time when patient presents to you, one is the patient is in shock and there is multi-organ failure. So both conditions can have deranged in the kidney function test. So many times what clinicians do is that because the kidney functions are compromised, they reduce the dosing of the antibiotic. So it is very important here because one thing is this shock is not blood loss, your fluid volume is higher. And second thing is you are targeting at some infection. So your antibiotic should be in the full dose. So first dose should never be compromised. You have to give the first dose as a highest dose which is recommended for any infection. And then later on the doses can be adjusted according to the creatinine clearance. So this is very important to prevent the emergence of the antimicrobial resistance, that when you give antibiotics, they should be given in the full dose. You should never give in the low doses. And selection of antibiotics. Now see why we said it is important that you collect blood cultures, because what antibiotics you would be giving to the patient will depend upon what is the local microbial susceptibility of your center. And also other things which are taken into consideration is what is the suspected site of infection and whether the infection is acquired in the community or it is a nosocomial infection. So all these things will guide what kind of broad spectrum antibiotics we will be using. So if you just go through this chart, which is a study which was done, published in 2006, that it was seen that if you delay the effective levels of achieving antibiotics, there is fall in the survival rate of the patients. So if the effective antibiotics are started within 1 hour, the survival rates can be as high as more than 80%. Now, to guide, which antibiotics to use, we have Government of India antimicrobial policy. Grossly, broadly speaking, there are 2 antibiotics which are very important for gynecologists and obstetricians. This is piperacillin tazobactam combination, which is given as 4.5 gram IV 6 hourly. So first dose, complete dose, and then maybe you can modify it according to the creatinine clearance. And second is cefoperazone sulbactam combination. So these 2, they form most of the times, I'll just be showing you various infections where the antibiotic recommendations are given by Government of India. These 2 form a basic, the antibiotics which should be given in the patients, especially who are in suspect infection is hospital acquired, and you suspect it can be a MRSA, can have methicillin resistant staph aureus. So in those cases, you have to give vancomycin or teicoplanin to the patient. So for chorioamnionitis, it is important to have clindamycin, vanco, or teicoplanin cover along with cefoperazone sulbactam. You can also use tazobactam piperacillin combination in place of the cefoperazone sulbactam. In septic abortion, endometritis also, you can give either piperacillin tazobactam or cefoperazone sulbactam combination, and alternatives are also available. So if it is, not just some infection, no dysregulated host response, and SOFA score is normal, then you can just give ampicillin and metronidazole. But in higher infections, you have to put the patient on higher broad spectrum antibiotics. In complicated pyelonephritis, along with this, you have other options available, which are in the form of aminoglycosides, like amikacin can be given, or carbapenem can be given. Imipenem or meropenem can be started in the patients who have urinary tract infection. Necrotizing fasciitis is also another life-threatening condition. So here, either piperacillin tazobactam or cefoperazone sulbactam along with clindamycin is recommended. You have a choice of giving carbapenem along with clindamycin or linezolide or daptomycin. Then secondary peritonitis, intra-abdominal infections, GI perforations, also piperacillin tazobactam. This is given along with now. So here, if your patient is very sick, you may have to put the patient on antifungals also. So the patients who have neutropenia, in those patients, you can give fluconazole 800 milligram loading dose, which will be followed by 400 milligram OD. So generally, along with starting antibiotics, source control is very important. If there is a source of infection that needs to be taken care of, any collection needs to be drained, any abscess needs to be drained. So if you have excellent source control, then you may not have to give antibiotic for a longer duration. But it is possible that the source of infection is deep-seated, or it is not possible to drain that source. In those cases, 2 to 3 weeks antibiotics may be needed in these patients. So there are international guidelines also for the septic shock. They also say that you have to see when the patient has septic shock, at least 2 classes of antibiotics need to be given. So one antibiotic is for the MRSA cover, and second set of antibiotic, if you do not suspect Pseudomonas, then only one antibiotic from 3rd or 4th generation cephalosporin or beta-lactamase inhibitor or carbapenem can be given. If you suspect Pseudomonas infection, then you have to give antibiotics which are and have anti-pseudomonal activity. So in this, we have anti-pseudomonal cephalosporins also, carbapenem also, beta-lactamase inhibitors, and fluoroquinolones. The ciprofloxacin has a very good anti-pseudomonal activity, and aminoglycosides like gentamicin, amikacin, or monobactam. Now, the important thing is, if you suspect Pseudomonas infection, so when you empirically give antibiotic, you give 2 antibiotics from this, at least 2 type of antibiotics should be given from these antibiotic choices which are there. Now, we have to also take care of antibiotic resistance development. So it is important that as soon as you have your culture reports available, you should de-escalate antimicrobial therapy. So it is not that initially we have started the broad spectrum antibiotics and you will just continue with them. So with the cultures, you have to de-escalate, and also you see the clinical response. So every day you assess the patient if you can reduce the number of antibiotics or which antibiotics you need to continue. So again, here very important. So I'm de-stressing. Source control is very important. You cannot neglect the control. Like if there is any collection that needs to be drained, any infection that has to be controlled by operative intervention if required. Then the next point here is rapid administration of fluids. This has already been dealt by Dr. Jyotsna Suri in detail. So I would just like to emphasize that it is at 30 ml per kg of crystalloids are given. State levels are more than 4 millimoles per liter. Colloids, they do not have any advantage, but they can cause harm than good. Hence, the hydroxyethyl starch is one colloid which should never be given in the patients who have septic shock, because this can lead to increase in the mortality and acute kidney injury. Then the fifth point in the 1 hour bundle is the use of vasopressors. So I've already highlighted that in the 3 hour and 6 hour bundle, the emphasis was in giving fluid replacement and then vasopressors if fluid resuscitation was not able to achieve the desired response in the mean arterial pressure. But here now it is said that along with the fluid resuscitation, if the patient's BP is persistently mean arterial pressure is less than 65 millimeter of mercury, then you can start the vasopressors. Noradrenaline is the drug of choice which will be given. And here just one caution is there, that vasopressors should not be given in patients who have hypovolemic shock unless you have done aggressive fluid resuscitation. So it is only for the septic shock that you can give vasopressors side by side along with the fluid resuscitation. So noradrenaline is the drug of choice, and in septic shock, it is given in higher doses. You have the option of giving noradrenaline either by infusion pump or by the micro drip sets which are available. So if you are not able to control the blood pressure, not able to bring it above 65, mean arterial pressure above 65 millimeter of mercury, then the other choices of vasopressors are adrenaline and vasopressin. Dopamine should only be given, it is an inotrope, it is not a vasopressor. So this thing should be kept in mind, and it can lead to tachyarrhythmia. So the patients who are at low risk of tachyarrhythmias, there you can consider dopamine after giving other vasopressors. Phenylephrine are not used in septic shock. Then in addition to this 1 hour bundle, these 5 points which are there, other additional therapies are also important in the management of septic shock. Very important is initially also you have to stabilize respiration. You have to start oxygen because there is tissue hypoperfusion. So oxygen therapy is very important, and you monitor the oxygen saturation with continuous pulse oximetry. Intubation may be required early in patients who have septic shock. Glucocorticoids can be of use in patients who have received adequate fluid resuscitation, and vasopressors have been administered, but still their BP is not above 65 millimeter of mercury. And venous thromboembolism prophylaxis is very important because septic patients are patients with sepsis and septic shock. They are going to be there with us for a longer duration. And also prophylaxis for stress ulcers should also be started. Immunoglobulins are in the experimental phase till now. Then intensive insulin therapy that should be given. Generally, these patients may have hyperglycemia. So our aim is to keep the blood sugar levels between 140 to 180 milligram per cent. And they may have fever. So external cooling and use of antipyretics to be done accordingly. Nutrition has to be taken care of. Early nutrition should be started in these patients. And also early renal replacement therapies associated with higher survival rates. Role of bicarbonate is only if the pH is less than 7.1. Before that, you should concentrate on resuscitating the patient rather than starting bicarbonate therapy in the early course of the disease. Now, the very important thing is which is there is that why after knowing so much about septic shock and after knowing the importance of the fluids, antibiotics and all, still we are not able to achieve these things within 1 hour of presentation of patient is that there are certain disbeliefs which are associated with sepsis. One thing is that nobody takes it as an emergency. So this is one very important thing, that septic shock should be treated as medical emergency, because here, deaths are not very early. Here the deaths are late. So it is not like hemorrhagic shock and all that patient will die within an hour or so. So here, that is why some people may not recognize it as medical emergency. Then there is a belief that if you use too much of broad spectrum antibiotics, it will lead to antibiotic resistance in the patient. And then also few people feel that 30 ml per kg of fluid is too much for the patient. And here, comes the importance of various tests which Dr. Jyotsna have already highlighted, that if you are in doubt in some patients who have underlying cardiac problem or something, you can just go for dynamic test for fluid requirement, and you can just guide your fluid therapy according to that. But all patients who come in shock should receive initial 500 ml bolus, and then you can assess further and then give the fluid replacement accordingly. But patients who do not have any underlying disorder, there you can continue with your resuscitation of 30 ml per kg. And the reason for this, as I've already said, that sepsis does not evolve as rapidly as cardiac death or traumatic hemorrhage. And because sepsis is slow evolving, neither the emergency department personnel nor the critical care physician, they see the full clinical picture from beginning to end. So people who are resuscitating the patients initially in the emergency may not see these patients die, because these patients may die, after a day, 2 days, or maybe after a week or so. So this is a summary of the 1 hour bundle. The first thing is that you have to measure lactate. So ABG has to be done, obtain blood culture before you start antimicrobial therapy. Then third thing is you administer broad spectrum antibiotics. Then you give a rapid fluid resuscitation is done with 30 ml per kg of crystalloids. Vasopressors should be started early in the course of the, during the presentation of the patient. Thank you for your patient hearing. Yeah.
Thank you, Dr. Rekha. Sepsis is a life-threatening condition, and you have really enlightened us with these slides. The case was the topic was very well presented, and you have made it very clear for us when and what to do.
Yeah. Thank you very much once again, Dr. Rekha and Dr. Jyoti, for organizing this topic to be rediscovered by all of us. And I thank Dr. Pratima and Dr. Jyotsna and Dr. Rekha for enlightening us and presenting such a complex topic in such a simplified manner. And I had, like Dr. Kishore also mentioned, I had made it mandatory for all my resident faculty to attend today's webinar so that these things become crystal clear and point to us. And sepsis is one thing. The main important points, like take-home messages, are early recognition of sepsis. This is what we do is we fail to recognize that, and what happens when the patient goes into shock. Then the residents keep telling us, "Ki, madam, ye ho gaya, wo ho gaya," and also very important point is, as seniors, we should be on our rounds, be vigilant to pick up that one patient amongst a whole lot of patients which we have in public hospitals. These days, particularly, we are overflowing with patients everywhere in all the primary, secondary, tertiary centers. The most important point is early identification of sepsis, as Dr. Rekha clearly pointed out. And for all the residents and all of the obstetricians to know the physiological changes which are occurring, which were very beautifully highlighted by Dr. Pratima ma'am. And one thing I would like to say, add here is, as Dr. Sharda Jain ma'am has also said, the training part. We should have these as a part of these bundles, the sepsis bundle, PPH bundle, all these should be a part of a training curriculum and modules. And like we have BLS training, ACLS mandatory, ATLS training mandatory, a student should not be allowed to sit in an exam unless they clear these exams. They should be part of the curriculum, and also undergraduations, post-graduations particularly, and for all our DNB residents which are there. And when we come as obstetricians, we should be having these trainings, and these drills should be a part made mandatory to clear and reorient ourselves and learn the latest also. I cannot say I'm heading a department, I am a senior, I'm a consultant. No, I also need to be updated and keep abreast. And each one of us, like I would like to highlight here a few points which were said. The antibiotics. Hospitals must have their own antibiotic policies. Yes, Government of India has given us beautiful guidelines we have now. A lot of work is being done in obstetrics, and we were initially focusing on the neonatal mortality, but now the focus is on maternal mortality, how to go about reducing it. But the mother is safe, mother is fine, we manage the mother well, neonates will be taken care of. And we need to have our antibiotic policies, and we should know, we should hit hard and hit fast. Like Dr. Rekha mentioned, full dose, first dose should be the maximum dose. Only then we will be achieving this benefit. And also these charts, madam, you beautifully highlighted all these charts highlighted by Dr. Pratima and Dr. Jyotsna. They should be put up in all our LRs for a ready reference, ready reckoners, not difficult to emulate. They should be there. And our residents need to be sensitized to use it. And one more thing I would like to highlight is for all our delegates who are listening and everyone who are in a position of authority to say, when we refer our patients, our referral should be very meticulous when we send to the higher center. It's such a haphazard referrals are there, just 2-3 lines, patient came, sepsis hua, 2-3 point written, refer, transfer. The importance of sending the charts so that the tertiary center knows what exactly has been done and what was the patient condition. So time zero, that time zero is very critical. And sepsis 1 hour bundle, it should be on tips. And it will really indeed go a long way to save our mothers. As we all know, still, since so many times, the top 3 killers remain are PPH sepsis. They are still there, and we have a lot of guidelines, but we are still back to square one, managing our PPH patients and managing our septic patients. Thank you very much once again.
Thank you once again, Dr. Rekha Bharti, for this very crisp and informative talk, and for emphasizing the first golden hour in managing septic shock. I would just like to request all our 3 honorable speakers that we would like to repeat this these talks again and again for our viewers, so that it stays in our mind forever. And we would also like to again request Dr. Pratima Mittal that we get to come to your HDU, to your obstetric HDU, to see how exactly you work. Thank you so much.
And I would like to add here, like this is a learning lesson for all of us, Savajan taking the lead in having an obstetric ICU in the country. Like we are also going for expansion, and this was my first request with the government and architects. I need a separate OBS, ICU, and a step-down HDU. We don't need a combined HDU because our patients never get a place there. So we are also going ahead with a dedicated OBS HDU and ICU, which is a need of the hour for all of us to be there.
Can I put one word here?
Yes, sir.
Actually, I just want to say that one practical point. When the patient is there and usko jaise blood loss bhi ho gaya, sab kuch ho gaya, and then you are managing it, the resident is managing. जब उसको fluid replacement के बाद भी उसका अगर BP नहीं आ रहा है, then they should click in their mind that it could be septic shock or septicemia. So वहाँ पे मतलब it should start clicking in their mind कि ये हो सकता है. Number 2, जो कई बार many patients have cardiomyopathies also. So उसमें you have to be quite careful when you give fluid replacement. जैसे preeclampsia में कहते हैं उसके अंदर भी you have to be. अच्छा, and number 3, what I want to say that ये जो SOFA score and all these scores, मतलब residents should write this in all patients. It is not that कि sick patient में लिखना है मैंने. If they start writing in all patients ना, अपने आप वो पार्ट हो जाएगा. हिस्ट्री ले रहे हैं, एग्जामिन कर रहे हैं, उस पर लिख दें इसका ये है, खत्म. सो दैट एटलीस्ट प्रैक्टिस हो जाएगी कि भाई जब पेशेंट आए, कोई भी पेशेंट आएगा उसमें अगर सिक पेशेंट होगा तो अपने आप ही लिखेंगे उसके अंदर. दिस इज व्हाट आई थिंक शुड बी. एंड एक पॉइंट बड़ा डॉक्टर जैन ने भी बोला था कि दैट द डिग्निटी, रिस्पेक्टफुल मैटरनल केयर इज वेरी वेरी इंपॉर्टेंट. इस सब के अंदर आप डू नॉट फॉरगेट दैट. मतलब shouting at the patient, hitting the patient, everything I have seen. So therefore that also should be respected. It is also a part कि ये नहीं कि sick patient आप उसको कुछ भी करो. कई बार वो they talk irrelevantly because they are in shock and तुम्हें तो पता चलता नहीं, and they think कि patient तो कुछ भी बोले जा रही है. That time I have seen so many times क्या क्या बोलते हैं मतलब उसको. So that also should be, and because I think एक point is that all of you or most of the gynecologists are females ज़्यादातर होती हैं, and they have the biggest advantage that they have themselves experienced so many things. So it is very easy for them to learn and to बता सकना अब ज़्यादा हमारे लिए it is more difficult because हम तो पढ़ के बताएंगे क्या हो रहा है. But all of you, I think बहुत आसान है आपके लिए बताना, and therefore मैं जब देखता हूँ ना respectful वाला, तब मेरे को आता है जब उनके ऊपर हो तब तो how come they talk like that to the patients? So these are the some points.
I would like to intervene here, sir. Things are changing, and our labor rooms
That
are no
we know,
longer
we have
what
not
they used to be
yet.
15, 10 years back. Our labor rooms are definitely changing. The
I
level
know
of
it,
care,
I
even
know
in
it,
the
but I
government,
just wanted to stress that
much improved.
it
Ma'am,
requires
I think you would agree with me. We are changing a lot, and residents need to be sensitized. And with seniors, we have to take them a task if anybody says anything to a patient. That has to.
That is true.
The onus is on me then. If my residents are not behaving, the onus is on me. I have to take the blame then, not my residents.
Can I make up say something? I'm Dr. Abha.
मैडम बोली.
Yeah, मैं ये कह रही थी कि we were talking about the tertiary care and the resident point of view. So a lot of us are in practice, and then we do get so many referred patients from 1 kilometer to say maybe 50 kilometers outside Delhi and this part of Delhi. So there should be certain guidelines for those people also who are referring the patients. You know, many times we get the patients quite late when the patient is in irreversible shock. So there should be some warning signals where the cost is also is a consideration in private setup. So some guidelines or some views about that when they should be referring. Like IVF people very clearly say these are the indications when you should send the patient for IVF. So when earliest they should start considering sending the patients to higher centers so that the precious time is not lost.
Thank you, Abha. I would like to respond to all these, questions which you have raised. First of all, to Dr. Mani, I think Mani and Dr. Divya also, I think, wanted these classes. Definitely, we advocate having these classes, and we will be most willing. And Dr. Sharda Jain has really, encouraged me and really pushed me, inspired me. So we will make a sort of a course, and we will make. I think it will be online teaching only in this era, and we will definitely make a course, and so those courses can be repeated every 6 months or every 1 year, so these students, everybody can learn. First thing is. The second thing is, as far as labor room is concerned, I think we have to start in a phased manner. As Dr. Kishore is saying, that they should be in the habit of putting. But if you start putting everything, then it gets diluted. Then they sometimes, it is just as a, randomly, they are just doing it, intern kar dega, intern bhar dega. तो उसमें उसकी वो नहीं होती. I think we should start with high risk patients first. And then we should, we should start with high-risk patient, and then we adapt it universally. And to Dr. Abha Sood, I would say that we have as a requested government that we should train these people in this modified early warning course to the peripheries. The patient, we tried, in the Faridabad and Gurgaon, where the patients are being referred, maximum number of patients were being referred from there. But somehow or the other, these things could not be finalized. But it is very, very important that all of us, we as a gynecologist, each one of us, senior people, even you are a private practitioner, you can also teach, you should take certain areas from where the patients are coming. And we have got a standard guidelines. This Muse chart is there. So you can really tell them that you follow these charts. So if whatever area you come in contact, I think everybody can make a difference. Every small activity will make a difference. I think that we have to really work harder. Government is trying. They were trying initially. Deputy Commissioner of Maternal Health wanted that peripheral centers we should include this Muse chart. but somehow it did not become, real, it did not come into practice. So that
Dr.
very good suggestion.
Pratima,
Yes.
I was just thinking that, if you have a course on training of trainers, see, then only we will succeed, because it's very difficult to send everybody to Safdarjung. But just train certain trainers, and let's make it a point that we further train the people in our own departments in a meticulous and proper manner. Because unless it's done in a methodical and proper manner, we will not succeed. And secondly, to respond to Dr. Abha, I think the only thing we at our end can do is that whenever you are getting such a patient from a center, I think there's no harm in giving a call to that center and telling them,
Yeah.
and we don't actually, once the patient is done with, managed here, well, we forget about it. We must give a feedback to the center concerned and tell them that, we would have appreciated that if you had given these details, and, so that at least when the next time a patient is being sent, they would send with a proper referral. And also it may get a message that, of course, these are the things which they should have at least done. See, we are not criticizing, it's just for the next patient, when the patient is coming, things are better.
That's very right, Dr. Punita. This is a very good suggestion to give the feedback.
Yeah, which we don't do because we are all busy in our setup. And then we forget about giving a feedback to the concerned institution.
And Punita, your point is well taken. We will definitely arrange these TOTs, but with all the conferences, we are doing a workshop. Almost every 3 months, we are doing a workshop. But so that is being done. But practically, I think if you want the TOTs, we can include case studies and all. We can do that. That is a much good idea.
Yes, ma'am. At least on the government sector level, we can do TOT, so then we can further infiltrate and teach all the residents and all the hospitals concerned with us, our district wise, we can then carry it forward.
Now, Rekha
rightfully said,
Rekha and Jyotsna have to do it. They are the, they have to continue this.
Right now, we are managing fine. If we have to refer patients, we talk to Dr. Jyotsna, he assess a patient, we have to refer her, and availability of bed is found, and one-to-one we are referring at the moment. And yes, Safdarjung never refuses a sick patient.
Safdarjung has never
refused. Has been a backbone during this COVID times for us.
And I think
there was a move by the government to have HDUs in all hospitals, but somehow it didn't work out because the peripheral hospitals are working with very thin staff, and and probably the confidence is not there. Reason being that we are lacking the training also. So it's not only the infrastructure, the training, it's also, the scanty number of residents I keep reading who are managing the show. I think it's very difficult to run the HDU, but we are getting motivated by the pioneer example set by Safdarjung.
One thing which I want to say is that obstetricians have to be confident within themselves. हमारे obstetrician के क्या है, anesthetist कर सकता है, हम तो नहीं manage कर. They're so scared, So that's
absolutely.
Fear of we cannot manage. This is anesthetist job. That has to go out because anesthetist is just managing the invasive ventilation. Rest all, even nurses, हमारी nurses इतना अच्छा ventilator manage करती हैं, मतलब वो तुम्हें सारा सिखा देंगी.
Absolutely, very well said.
The patient belongs to us, so we need to manage our own HDUs actually.
Yes, we have to be comfortable. We have to be confident that we can manage our obstetric. We know how much fluid to give. Anesthetist क्या extra करेंगे, है ना? बल्कि we are able to manage the baby as well as the cesarean and everything we can do. So plan.
वही है Dr. Pratima, the dependency on the anesthetist जो पुराना चलता आ रहा है वो अभी भी चलता आ रहा है. It's time that we should change, and I think people like you, we take your help, your expertise, and your training, which will definitely help.
And Rekha, they are the pillars. They are my pillars.
Yeah. I know Jyotsna has been very actively involved in it, and I think she's managing the HDU very well. We keep hearing, and thanks to Jyotsna, Rekha, both of you, and of course the leadership of Dr. Pratima, everybody as a team has been doing excellently. Thank you once again for participating in our webinar, and I think we've got a very clear, good messages. Thank you once again.
One more, I think prospect of COVID also now should be added. It is not that COVID is not affecting our mortality. I think it has some effect on our maternal mortality also. So I think that aspect also should not be ignored.
So let's hope COVID now will, gradually
No, it is.
decrease, and we will
We
focus
don't know
more
about the
on
next
our
wave.
own
We don't
maternal.
know anything. We don't know anything.
Yeah, but let's hope that, but that doesn't mean that we will not focus on these important things, Dr. Kishore.
Yes, yes. No,
We'll
no,
have
I'm
to do
saying
that.
add to it. COVID also should be added.
Yeah, yeah.
Pratima,
That's
I would request to make a small 5-page algorithms for from your hospital. I mean, your critical care team can make, and those can be circulated among the private practitioners, and they can be put in the labor room. So whatever important just from the 3 talks that we've got, the 3 maybe 5 to 7 algorithms that the private practitioners can have, because if we have the knowledge, then the fear is gone. That is why we are fearful, because we feel that we don't understand shock very well. So that is, if we can have such algorithms from you, and those can be shared with the private practitioners and all the hospitals, so that would be wonderful. And such sort of
we can request Jyoti, we can request Dr. Jyotsna and Dr. Rekha to share the charts which they are preparing, they are showing in their labor rooms. And I mean, if they can share their presentation, we can at least make the charts ourselves out of those and share it with the residents. So it's a request to them. If it is possible, we can do that, because we can't burden them for preparing the charts also for us. So if they can share their presentations, we can prepare a summary chart and circulate in our.
I'll coordinate with Dr. Jyotsna ma'am and Dr. Rekha and Dr. Pratima if few whatever important ones, because if we have 10 of them, then again they go waste. If we have very few important ones, then everybody can just go through them just at a bird's eye view. It should be placed in every labor room, so that things become very, very clear to each one of us. So thank you, Dr. Pratima ma'am, Dr. Jyotsna, Dr. Rekha, and the whole critical care team of Safdarjung for giving us this overview of everything that we knew, though it was, there were so many new things that added to our knowledge today. And thank you again. I think the vote of thanks I only will have to give to our chief guest, Dr. Sharda Jain ma'am, our Dr. Sanjeevani Khanna, Dr. Guest of Honor, and Dr. Sushila Gupta, the special guest that we had today, the 3 speakers, the wonderful speakers, and our chairpersons, Dr. Leena, Dr. Abasu, Dr. Mrinalini, and Dr. Divya Singhal from the various other DGF forums, and our DGF Outer Delhi team, Dr. Kishore, the president, Dr. Punita, senior vice president, Dr. Alka Jain, vice president, and the 2 treasurers, Dr. Ekta Bajaj and Dr. Anita. So the whole team, thank you all, and thank you, Shield team. So
in the end, I would like to say that Dr. Jyoti, you are really taking the initiative of organizing. We in fact must thank you for organizing such a webinar.
Thank you so much, ma'am. Thank you.
Thank you. Bye-bye.
Have a nice day. Bye-bye.
Bye.
Thank you all, doctors, on behalf of Shield.
Yeah, thank you, Shield. Thank you, Mr.
Yes, ma'am. Thank you. Yes, ma'am. Thank you.
Mr. Someshwar.
Right, ma'am. Thank you.